improve digitalization of adolescent youth services, such as improving access to TICO and online apps that make service delivery easy for young people online.
So, in order to identify innovative solutions for advancing adolescent health in Uganda, we recommend that, point 1, there is need to increase awareness on adolescent health issues and their impact on development among different structures at the national and district level, like parliament, finance committees, and so on. Second point, continuous health education of adolescents through user-friendly materials and video content, which attracts many users, especially social media channels. Third point, strengthen adolescent-friendly services, making them more accessible and efficient, like building of ramps, adjustable beds, translating information into brailles, and sign language interpreters. The fourth point, activating the district adolescent health committees to become more efficient in promotion of adolescent health policies and strategies. The fifth point, training and facilitating adolescent or peer health educator movements to advance positive health practices among young people in schools and communities, not forgetting that marginalized and special needs groups. Last point, advocating for sexual education, starting right away from primary schools and training the senior women teachers. Last point, increase empowerment and involvement of more boys in empowerment and supportive programs so that they aren't left behind.
Then finally, we as the youth, we propose the following as the possible ways of working and leveraging diverse expertise and resources to drive sustainable change in adolescent health indicators. Then, it is essential for government to prioritize inclusive health financing policies that cater to the diverse needs of adolescents. This can involve allocating sufficient resources to support youth-friendly services, sexual reproductive health information, and tailored healthcare programs that consider the specific requirements for adolescents with disabilities and diverse gender identities. Secondly, investing in training a range of healthcare providers and duty bearers to deliver inclusive and culturally sensitive care can significantly improve access to quality healthcare services for all adolescents in Uganda. Capacity building programs for adolescents and young people. Engaging young people at all levels through adolescent economic awareness camps and budgetary processes to make young people actively participate in decision-making processes. Meaningful and inclusive participation of young persons with disabilities call upon respective government agencies to endeavor to include persons with disabilities in aid or economic empowerment programs like PDM to ensure the 10% is benefited from by allocating it to their training and skilling centers. Multi-sectoral collaboration between Ministry of Health, Ministry of Education and Sports, and Ministry and other ministries, strengthening collaborations between line ministries, duty bearers, and young people in implementing comprehensive sexuality and behavior change communication programs for disease and violence prevention, including menstrual hygiene education in schools and communities. Multi-sectoral collaboration between, intensification of advocacy, advocate for budget allocation for key adolescent health services, such as availing and increasing availability of vital and wellness care products on the national medical store supplies, such as sunscreens, for albinos, those with epilepsy, and other non-communicable diseases. Then finally, put social accountability at the heart of healthcare providers, DCAs, NGOs, line ministries, and policy implementers, so that each stakeholder is held accountable in achievement of better adolescent health outcomes. Thank you for God and our country.
Thank you very much, colleagues. That was quite very, very comprehensive. And I think the colleagues here from the various government ministries, departments, agencies, our development partners, you've heard those very pertinent issues that are concerning the adolescents and young people in this country. They've made a very comprehensive summary of what transpired yesterday, and their issues have been raised, their recommendations, and issues that they want us to look at. And I think that sets our conversations for today. I see very many officials in this room. I welcome the honorable members of parliament who have joined us along the way, and other ministry officials. I see the adolescent and school health department is very represented in this meeting from the Ministry of Health. And I'm sure in the later sessions that we'll be having as part of the panel discussions, most of the issues that have been raised by the adolescents and young people before us today will have a reflection and a conversation on those issues, and we see how we take them forward in our planning, programming, as well as implementation as we engage the adolescents and young people. We'll have one final speaker, and then we go into a health break. So I want to invite Michelle to present for us the CSO position paper. And you'll also be raising issues that we think are quite important for us as we prepare for the next panel sessions that will be beginning after the health break. So Michelle, proceed. Mitchell.
Good morning, ladies and gentlemen. Does this room have adolescents and youth? Good morning, ladies and gentlemen. Okay, almost there. Okay, my name is Mitchell Ainebiona. I work with Save the Children. I work with Save the Children as a specialist on public investment in children. Okay, so what I'm going to present is just a snapshot or highlights of what has come from civil society, and not so different from what has been shared by the different speakers that have spoken before, especially the adolescents, because this is the perspective that we come from. And most of this is from analysis of the different budget documents since January and the previous years, trying to assess and see the gaps within financing for adolescent health. So there are some things that I've teased out here, and I'm going to be highlighting that I hope will preempt the panel discussions that are going to follow through and the other discussions that are going to be coming from government to clarify on some of these and what they're doing about them. So colleagues, I know that since yesterday in this room, there's been consensus and an agreement that adolescent health is quite important and is very critical in improving the survival and well-being of adolescents. That's without a doubt. And if we intend to achieve some of the agendas as a country that we want to see, financing towards adolescent health is quite critical. That one we have consensus on, right from yesterday's discussions. We have a very amazing sharpened plan of the RMNHCA, that is very, very clear on some of the things that they would want to do from the government's perspective in regards to strengthening the adolescent health. In here, one of the key elements in that plan is that some of these will be achieved through adequate financing towards reproductive health and adolescent health. Very, very important that we appreciate this, and we even now have it in the plans. And that's something that we would want to commend highly the Ministry of Health for. A hand clap to them, please. So this plan points out about 3 critical areas that were our basis of interrogating to try and assess some of the gaps in here. And one of them was the provision of appealing and actionable data and information on adolescent health, data and information, number 1. The other one was on school-based and school-linked health facilities. The other one was establishing some sort of at least feedback mechanism from what is coming through from the interventions that are being designed versus what is coming through. Well put and very, very clear. But when it comes to financing, how is this being actualized? So I extracted some figures from the various approved budget estimates just to try and set of how, as a country, we've set ourselves against the different targets, including the Abuja Declaration that we talk of so much right from yesterday, just to assess how are we doing. And in the recent financial years, we have stagnated slightly at about 7.7 against the target of 15. So those are some of the discussions that internally we have the plans right. When it comes to the financing, where are we getting it wrong and what can we improve? The other one, when you interrogate, if you get into economic classification, that is wages, maybe the recurrent, the development expenditure. I also teased that out to see, especially on the wages, since that's a component that has been coming out strongly, hindering financing of adolescent health. You find maybe the staffing is so limited to attend to adolescent-related discussions. Ladies and gentlemen, I've also found that there are some gaps in here and that we have been declining on the staffing, at least on the wage, from about 33 to about 24%. And we're way below within the region. The region average is around 45 to 60. So we're still a bit low. I know in the current budget, government has put in some money to recruit more, and that's something that we're looking forward to see how this will be actualized. The other argument, we also now know from the people that are in this room, a number of them are from the subnational, from the districts that we represent. So I assessed to see what's coming in at national level, what's coming to the subnational governments, where most of the brunt of the services to adolescent health are. I've also found some disparities there and some gaps that I think we should discuss and see how we can close some of these. So we have also noticed that the biggest percentage of adolescent financing stops at the national level and doesn't reach. The figure that I found there was about 17% is what goes to the districts. And yet this is where the brunt is, the provision of all the FP services, the youth-friendly corners, and so on and so forth. So this is an area of concern, and we see how we can improve this. So overall, I picked about 4 key concerns. There were a number, and the youth and the adolescents have already mentioned in their communique, but I just picked out 4 that are financing related, that I know if addressed would give us so much mileage in addressing all the gaps within adolescent health financing. Number 1, like I mentioned, we have amazing strategies and plans of how to push adolescent health financing. In the amazing plan that I've talked about, the sharpened plan, but when you interrogate the budget within that plan versus what is coming into our annual budgets, there's a big disparity in there in achieving those plans, which begs the question, how are we going to actually actualize this in the timeline we've set? That's number 1. The other bit is on the overall spending, per capita spending. We're still a bit lower. Yes, there are some efforts that are coming through from government, but we're still a bit low compared to the region. We're about 50 USD against about, they required about 86 at least to have very decent health service provision. The other concern, and I know you've had this in the recent years, is on the external financing of the health sector. This is, of course, a big concern. And increasingly, we are seeing cases of donor fatigue, other priorities whereby they're not keen on prioritizing any other thing that is not within their priorities. And the other bit, when you look at the budget document, you find that there's a considerable percentage of budget from the external financing. That yes, the hand that is coming through, but most of it is being channeled through the off budget, which has a shortfall in that it reduces government's flexibility in resource allocation towards the reason that we are here, for example, in adolescent health. It limits the ability for government to allocate to some of the asks that we have today. So this is an area that we may need to look into and see how we can address. Finally, is on that this spending, like I'd mentioned earlier, is still skewed a bit more to the national level. And we understand there's some level of service provision that the national level service providers give, but the biggest branch from the analysis that we are seeing is actually down at the subnational. How do we strengthen this is a discussion. Because we've noticed that only 17% of the total public spending goes to the district level, 17%, okay? So this is something that I think we need to discuss and see how to solve. So what are we recommending? 3 key recommendations from what I have highlighted. Number 1, of course, the need to address the PHC funding, which is quite meager in achieving what we want to see. This will go a long way in helping to functionalize our facilities, especially including the provision of the adolescent health services that we much need in this discussion. The other one that I have mentioned that we really should be watching closely is the external financing discussion and the unpredictability increasingly given to some of our stances that we have as a country that may not be in agreement with some of these external partners and the different ODA that is coming in. So this is one that we need to have a backup plan in the event this should come out. Will our health system be able to stand? It's another area. Finally, we've also noted that a number of plans that were displayed here from the Ministry of Health colleagues, we've also found that when we asked a few districts that are even represented here, that some of the plans and the policies that are designed don't actually get to them. In other words, they are not disseminated. The few that are disseminated, it's one-offs, maybe 1 or 2 days workshop, and you expect the district to understand an entire policy document that you've been designing for over 2 years to understand it in 2 days workshop. Yet this is the document that's going to inform the planning and guiding. And remember, in the districts, there's a high attrition. Different people are leaving. The people you train this year are not the people who will be there next year, and yet the people who are going to be planning for our adolescents. So this is something that would be good to, as you disseminate, organize joint periodic, and this is from the Ministry of Health. We've seen some components of education. We've seen some components of Ministry of Gender that to do with mindset change and awareness creation. So that concerted effort would go a long way. Finally, ladies and gentlemen, I can't emphasize enough that we can't do this as one entity. This is a joint effort. Where the Ministry of Finance cannot handle, the Ministry of Health would come through, the Ministry of Education, the local governments, Ministry of Gender, and even the civil society and development partners that you've seen contribute highly to this budget. So this is a concerted effort that we need to work with together to achieve. Finally, it's key that as we design some of these interventions, a number of hard-to-reach areas that are left out. We've noticed. The Ministry of Health yesterday showed us a map of Uganda and highlighted districts that were in a very deep red. And if you notice, a number of these interventions don't reach. We design amazing. I don't know, they usually stay within the centers. It's important that as we design these interventions, we ensure that they reach even those hard-to-reach areas to have a more equitable and wholesome address of adolescent health financing. Ladies and gentlemen, thank you very much for listening.
Thank you, Mr. Ainebiona, for that comprehensive presentation. All the CSOs here, all the organizations, I hope we put all the issues he has put across into consideration. As he has said, we need to have a joint effort for everyone to make sure that the adolescent health is up to scale. Before you go for our break, I want us to hear from some of our key stakeholders that have come in after the introductions. kindly requesting that you introduce yourself so that the people in the room, then most of the youth and the adolescents can get to know you better.
Thank you. Good morning, everyone. My name is Dr. Rutaigwa Elisa. I represent the people of Rukungiri municipality. I'm happy to be with the youth.
You're most welcome.
Thank you. Good morning, everyone. My name is Richard Gafabusa. I'm a member of parliament for Boamba County in Bondivujo district. Bondivujo is at the extreme border with DR Congo. In the mountains, that's where I'm very short. You know, in the mountains, you have to be down to earth.
I think old age, I don't know how to handle this. Yes, honorable colleagues, ladies and gentlemen, good morning. My name is Salongo Kakembo Mikairi Mbwatekamwa. I represent the people of Entebbe municipality in this parliament. I'm so happy to associate myself with my children. You're welcome.
Yeah. You're most welcome to the third National Stakeholders Dialogue on Adolescent Health 2024. We have other stakeholders here.
Thank you so much. My name is Roland Njomjenyi Bish. I'm a member of parliament representing Ruchiga. And Ruchiga is both a county and a language. So I represent every person who speaks Ruchiga. I am also the chairperson of the Parliamentary Forum on Labor, Decent Employment and Productivity, and also the chairperson of Parliamentary Forum on Housing. I'm happy to be here. Thank you so much.
You're most welcome to this dialogue.
Thank you very much. Our leaders, especially those at Parliament, our national leaders, those at the sub-national, distinguished participants, a very good morning to you. I am David Okwi. I am an acting principal economist with the Ministry of Finance, working with the Budget Directorate. Glad to come and share with you how we prioritize young people in the budget. Thank you very much.
You're most welcome.
Good morning, dear team. Reverend Nathan Mugalu. I am a senior adolescent, and that's the capacity in which I come here today. Thank you.
You're all welcome to this dialogue, and we hope to have a meaningful participation and discussion on this dialogue. At this juncture, we are going to have our tea break, which is going to take for 15 minutes. Yes, 15 minutes. But I would kindly beg that the honorables go first. I don't know, the person in charge of the welfare, I don't know which room you are going to have our break, to give us guidance on where you are going to have our break.
the adolescents can go fast because they are the ones who are still growing.
Okay, we can go have our break and then we come back for the next session. Okay, the adolescents first, then the senior adolescents, and then... Okay, 15 minutes. Thank you.
Ladies and gentlemen, I want to call us back so that we resume the next sessions. So those who are grabbing a cup of tea, you can move in with a cup of tea so that we don't lose much time. We have a lot of discussions for the day. So we are giving in only 3 minutes to wind up the health break and we resume the next session. So the colleagues outside kindly join us and we resume shortly. I want to welcome you back from the health break and also request the colleagues who have not yet joined us, who are outside there, to get in so that we don't leave you behind in these very important discussions for today. So we want to get into the next session, so we request you to settle down and then we resume the next sessions. We are not doing well with time, so I hope we can catch up as we go on. So we have a few more speakers who will usher us into the panel session, but before that, we are going to carry up one of the sessions that was supposed to come a bit later. That's on the financing for menstrual hygiene and management for adolescents. I will have Sehad, specifically Sifna Edith, the one you are calling Shifla, but she's Sifna. She's going to come and lead us into that short session. We request you keep it short to buy some time for other sessions. And after that, we will come Mr. Okwi David from Ministry of Finance. So Edith, you can take the stage.
Hi, everyone.
Connecting the mics.
Okay. Hello, everyone. Hi, everyone. If you can hear me, clap once. Okay, that is good. Welcome back from the health break. At least we've had our right to food being respected, okay? So I'm going to have a brief session, and this session, like Karim said, we are going to be sharing about financing for menstrual health. And as we all know, that the month of May was the month where we're celebrating menstrual health. And since we are here for the adolescent health dialogue, that means that is one of the key issues that we identify with, especially as adolescent girls and young women. And we are here to talk about the financing. So as we are all aware in Uganda that our health sector is not fully financed as we would wish for it to be financed. And because the priority mainly goes mainly to security and other issues in Uganda. But we know that health affects every one of us, whether you're a woman, whether you're a man, whether you're a girl or a boy. As long as you're a human being, health affects you. And when we talk about menstrual health, it does not only affect women and girls, but it affects you as a man because you are a brother, you are an uncle, you are a father, you are a husband. So that means it does what? It also affects you. And we all know that when we have, if our menstrual hygiene and health is protected as girls and women, it means that it is one of the empowering roles that we have that is going to help us to enjoy our future, that is going to help us to realize our full potential. Because if I'm in my periods, I'm able to access the sanitary towels, I'm able to access the water, I'm able to access soap, I'm able to access a changing room at school or at my place of work. That means I'm being respected as a woman, and my health is being respected. And it means that I'll be able to work and realize my full potential as a woman or as a girl that is going through my periods. However, we see that basing on the population that we have globally, majority of the of the people we have are women under the reproductive age. But we still have a challenge that these women are still facing limitations and challenges for them to enjoy their menstrual health. And this is because of so many reasons. For example, our social norms, cultural norms, and other practices. Then we have the stigma that is surrounding menstrual health. For example, when we look at the religious sects, we look at the culture that if you're in your periods, you cannot go maybe to a mosque to pray, or if you're in your periods, you cannot prepare for us food. And this has created a lot of stigma for the women and the girls. Then another one that we have is that we are unable to access the hygiene that we need during our menstrual periods. Reason being is that we, for example, as the country Uganda, we are characterized by a lot of poverty, and the girls or the women cannot access what they need during their menstrual periods. And this is affecting them. And that means if I cannot access a sanitary towel, I cannot go to school, I cannot go to work, and we are seeing that many girls are missing out of school because they cannot access the menstrual products that they need to help them during that sensitive month, that sensitive period of the month. So what are we going to do as stakeholders here? We are here to discuss as the adolescents, as our parliamentarians, as our politicians, our health workers, the CSOs that are here. How are we going to ensure that the young people, the girls and women, enjoy their menstrual period? And lastly is that we have limited financing for the menstruation. I remember one time, I think like 3 or 4 years back, our First Lady said that we shall be able to provide sanitary towels to all the girls in schools. But has it happened? That means we are not prioritizing this issue. And it means that we are affecting the potential of the girl child. And I think like last year or 2 years, I think throughout last year and this year, we've seen stories of girls in Busoga getting soil and molding it and using it as a sanitary towel. But can such a person go to school? Can such a person go to work? They cannot, because they are not protected and they are not safe. So these are things that we need to discuss. These are things that we need to talk about. What do we need is to improve the financing. We need to be intentional. Just like we care about the security of the country, we also need to care about the health of our girls and women within this country, that they enjoy their sexuality up to their full potential. Another thing that we are facing as a country is that when you look at most of our schools and higher institutions of learning and other institutions where we work from, both in public service and also the private sector, we see that we lack the basic facilities for us to enjoy, for us to utilize when we are in that special month, that special period of the year. For example, you go to a school, there is limited access to water. There is no like a special room for girls to change, and there are also no sanitary towels within those special rooms for them to change. And the girl puts on a sanitary towel from the morning when she goes to school till evening when she goes back home. And then she will reach home, there is no water, there is no soap. That means she cannot wash properly, and that means it is affecting her hygiene and health. So that's why we are calling upon every one of us that let's come up. It's the time now for us to be able to engage in giving accurate information about menstrual health and hygiene, but also fighting the stigma around menstrual health and hygiene. And then another thing is that for us to be able to provide safe and affordable materials for menstrual hygiene, and also being able to provide sanitation and washing facilities that will include hygienic disposal of the menstrual products. I'll go back to safe and affordable materials. most of the service providers may not be able to give us the safe and affordable sanitary materials because of the taxes that we have right now. And when we are talking about taxes, if you sit down and analyze, it's mainly affecting the women. Last year, we had our parliamentarians propose that we should have a tax imposed on the diapers. That is affecting the women. If we have the taxes increasing on every product, that means even the prices for menstrual hygiene products is going to increase. And that means it's going to affect our girls and the women who are mostly not part of the economic world, who are not employed, who are at home seated. And then also, another thing that we have to do is that we need to improve male involvement. If we ask our men who are here, that's how many of us as fathers take a time and buy these sanitary towels for our girls or for our wives, most of them will say that is the mother's what? Role. That is not my role as a father. But what if it comes a time and the mother is not around, and as the father, you're the only one around? How are you going to help your girl child to maneuver through that period of menstruation? And sometimes when we go to the rural communities, most of the fathers will say, but how can I waste my 3,000 or 5,000 to buy a sanitary towel for a girl? And what happens? This girl will be lured into early sexual activities with the border men, because this guy is giving her 5,000 every month, and she's getting money for a sanitary towel. After 3 months of providing, the border man will say, now it's time for what? For payback. And when payback comes, what happens? Pregnancy, and then the worst of the worst is what? HIV/AIDS. Or sometimes they end up into unsafe abortions, and some of them end up with complications, or they end up dying. So, for us to be able to create awareness as the Center for Health, Human Rights and Development, to be able to create awareness about menstrual health and management, we participated in a campaign in the month of May, where we had different stakeholders coming in, from young people, from ministry officials, from religious leaders, from CSOs, from politicians, participate in that campaign to discuss the environment around menstrual health management, to discuss how we can improve male involvement in menstrual hygiene, to discuss how we can improve the financing in male involvement. In menstrual hygiene. Why do we emphasize on financing? Because where there is no money, we cannot be able to access the menstrual hygiene that we need. So we need to engage ourselves in advocacy for financing, to increase the financing for our health sector, but most especially on menstrual health. So within this campaign, we had different people share their perspectives, share their cultural practices, the norms, the challenges. And the major issue that came out was the poverty surrounding menstrual health. And this has led many young girls or adolescents into unwanted sexual activities that has given them problems in the end. And then during that campaign, we realized that, yes, we have discussed all this. We have seen the challenges, money. We have seen the challenges, our cultural norms and practices. We have seen the less involvement of our fathers into menstrual health and management. What do we do as stakeholders? We came up with a menstrual health management challenge, and this was for the whole country to participate, for people to come up with innovative ways of how to come up with affordable, quality, but also safe menstrual hygiene materials. And we had over 10 people that participated in the challenge, but of course not everyone is a winner. So when we had this challenge, we got 3 winners from that campaign, and we said that, no, since we are going to participate in the National Stakeholders Dialogue on Adolescent Health, and we know that menstrual health is part of the adolescents, why don't we award these people before the adolescents, such that the adolescents get to learn from them. For them, what do they do? And what can we benefit from their innovation and from what they have been able to do, so that if I cannot access a soft care or an Oraze pad, at least I can have something that I can use as an alternative, but it is safe and it does not cause any health challenges to me. So with that, I would like to request you to help me welcome Tondo Sandra from the Women's Rights Initiative from Ginger to come and join me here on the stage. She was our second runner-up in the challenge. Sandra, you're welcome. Please come and join me here. And then as Sandra is coming, I would also like to welcome Otiang Christine. She's a community member from Moroto. Please, Christine, come and join us here. Christine is our first runner-up. I think you can also come, and she came with someone to support her. Maybe you can come and join us also, because we want her to be involved. We don't want to let her behind. Please come up. Then I would like to invite our winner of the challenge. And our winner is Sherina Ikipamung. She's a Youth Advisory Committee member from the SRHR Alliance. Sherina, you're most welcome. Yes, and before we award them, I'm just going to give them a minute, each of them, what motivated them to participate in this challenge. And since we are time limited, it's going to be a minute for all of you. Okay? Yes, and as they're talking to us, I'm going to use my powers to invite Reverend Nathan Mugaru to come and help me award these people. Reverend Nathan, please, sorry for hijacking you, but we are looking at male involvement and the involvement of different stakeholders in this challenge. So I'll start with Sandra, then I go to Christine.
Thank you so much. My name is Tondo Sandra. I'm here representing Women's Rights Initiative. Women's Rights Initiative. I have a small thing to say about our organization. We are based in Ginger. It's a non-profit organization that serves women and youth in area of empowerment and human rights in Busoga region. We are so intentional in supporting girls to strive, and we value every partner here, every partner with what should add to this struggle. Thank you so much. What motivated me was we do reusable pads. We have a production unit, and we also do awareness and trainings in schools and community. We train them on about how to use menstrual materials, menstrual hygiene, and everything. So, what inspired me so much was, in my region, we have girls that drop out of school because they cannot afford menstrual hygiene, they cannot afford menstrual products. So since we do hand sewing, I saw this challenge and I was like, we should take part of it because we do hand sewing whereby they can get materials in their local markets. So we came up with that skill. We do train in schools and even in community, because in Busoga, many girls get pregnant, drop out of school because they cannot afford pads, because 3,000 every month is too much for them. But they can afford these local materials in their local markets. Thank you.
Thank you so much, Sandra. Christine, would like to hear from you.
lakara ara ka krotiang Christine abuni tianga alakara maja. So
she's called Otiang Christine from Karamoja, specifically Moroto.
So kaina kinyayo boreni arai around the winner. A lot of madang Karamoja kama. Na iminyo yona kranga ber. Glodi yokiboy kini na dinyon.
Okay, what really inspired her is that looking at the context of Karamoja, as a woman or a young girl, when you go under your menstruation, you go and sit under the sun, and after that, your mother brings cow dung, and it is used for smearing you.
Aya neni asamti ango ke stanyut akidon ngapadangun ayo pe yalo de akitatama case akirimor lo community.
So she's a champion in our community, whereby she has inspired very many young women and girls on how to make reusable pads, and basically she uses the locally available material.
So naita neni alodi ango urari akesh.
So she usually does home visits to identify those adolescents that have already begun their menstruation, and then she tries to impact the skill. So that was from Straight Talk Foundation. We are in partnership with Sehad and Kifad. We are in Karamoja and Teso. Yeah, thank you.
A lovely good afternoon to everyone. Yes, once again, my name is Ikpamung Sharina. And before I say anything, I want to give special recognition to Mariana Kayaga and John Justin Awundesi, because they are the ones who pushed me to shoot this video. And one of the things that inspires me the most is we should never focus on only our problems when we can actually use available resources to solve our problems. So it was the other person who took me through the process of learning was Eric Omondi. He's the one who taught us the whole process of making the reusable pads. So with that information, I was empowered to share with other young people who can reach the video to make their own pads, other than having to spend $3,000 per month to buy a pad. So we can use our plate and other resources to make reusable pads, which are very much available. So that's all I have to say, but I'm really grateful for this opportunity. Thank you.
Thank you so much to our winners. And Reverend, since we don't have time, we shall start with awarding Sandra, and then we award Christine and Sherina. And then you give us just 1 minute speech. Sandra, please. Okay. Here.
Good morning, good afternoon. Good afternoon, dear participants. We are very excited to see the awarding ceremony for our champions for menstrual health. Menstrual health is not about women and girls only. Menstrual health is about men too. We cannot achieve period equity. We cannot achieve menstrual health justice if men and boys are not involved in the menstruation process. Therefore, our call to action, we have members of parliament here, subsidization of menstrual health products, but also the materials that you can use locally to make reusable sanitary pads. Number two, challenging all the negative or harmful cultural, religious norms, practices, and beliefs that promote stigma, discrimination, but also that say that when a girl starts menstruating, then she's ready for marriage, or she should go away from school, or she's now an adult. Number three, mobilizing religious and cultural leaders to take on the mantle towards making sure that menstruation stops being a curse. All of us are here because of menstruation. Not so? All of us are here because of menstruation. So menstruation is not a curse. Menstruation is not a problem. Menstruation is not a disease. All of us are here because of menstruation. If you think that menstruation is a feminine issue, you are lying. All of us are here because of menstruation. Number four, involving men and boys. Men and boys. Until now, we have men, adults. As a priest, this is an experience. Until now, we have men and boys who cannot be patient in homes when menstruation is happening. We still have men and boys who are not aware of the menstrual cycle. We have men and boys who cannot take care of the hormonal changes, changing in feelings, emotions due to the process. So involving men and boys, without you, we cannot achieve safe menstruation. So we thank everybody for participating, and decriminalization of menstruation, but also defeminization of menstruation. As one of the champions of men engagement in the country and out of the country, we can only achieve period equity when we defeminize. It's not all about women, it is also us. So men, where are you? Men, where are you, and boys? Don't get scared. Men, where are you, and boys? You are going to repeat after me. Menstruation is not all about women. Repeat after me, men and boys. It is also about us. We can only achieve period equity when we are involved. When girls begin menstruation, it does not mean they are ready for marriage. All together as men, for period equity. May God bless you.
Okay, thank you so much, Reverend, and thank you so much, everyone, and to our winners. Thank you so much. God bless you. Over to you, Karim.
Thank you, Sehad, for that wonderful presentation. Let's give a round of applause to the Sehad team. And thank you so much for recognizing the advocates in regards to safe menstrual hygiene. Thank you, thank you, thank you so much. The SEHAD team talked about how important financing is in accessing the health services. If there is no finances, we can't access the health services in the rightful way. At this juncture, allow me call upon a representative from the Ministry of Finance, Mr. Okwi David. He's going to guide us on how we CSOs can adopt to advocate for increased health budgets so that we can be able to improve on the accessibility of the health services in our different communities. Thank you. You're welcome.
A very good afternoon to you, ladies and gentlemen, in your distinguished capacities as our leaders, as our participants, as our organizers, and senior adolescents and the adolescents. I want to take you through a short presentation that I shared with somebody. I thought they would be able to cast it over here so you could follow. But nonetheless, by introduction, my name is David Okwi. I work with the Ministry of Finance, Planning and Economic Development in the Budget Directorate. I will take you through a presentation that will give us a background where we get our legal mandate to advocate for our health care, and our healthy being. We will look at the institutions, agencies that are under the health sub-program, which health sub-program is one of the thematic groups under the Human Capital Development Program that comprises gender, labor and social development, comprises education, and then the Ministry of Health. We will look at the health budget for the last 2 financial years. Why do we focus on those? We want to see, since we moved from the output approach to the program approach, where have the resources been focused? And then we look at the drivers that influence those allocations. We will also look at the gains that some of the allocations in the last 2 financial years and 5 to 10 years backwards have occasioned to our economy. And then we look at the lessons that we can take, both as adolescents, leaders, participants, and invited guests. And then we'll give the strategies for CSOs to enable them advocate for enhanced financing for the health sub-program within the country. So this is the context with which we know health. We know that it is one state, both physical and mental. We also know that it defines our well-being. So if you are well, free from illness, you could define yourself and say that I am a healthy person. That is the context with which we are presenting this. And we know that we have a right to influence the state of our health by either doing the things that are enhance a healthy living, or doing those that increase our risks and lead us towards unhealthy behavior and healthy situations. I'll give a simple example. If you did exercise, you enhance your health. If you have a sedentary lifestyle, and then you subject your health to a risk. You will also know that some factors are based on the structure of our society, so those are called structural. If our society shuns modern medicine, then we will not be able to get medical attention in times when we're unwell. When we have a developed society, like the one that the country aspires to have by 2040, then we know that the uptake of medicine will be high, and therefore the levels of our health will be improved, and so we have a decent well-being. We also know that if we have an educated society, it is very easy to comprehend interventions under health, and so that is why everybody should be able to access equal measure of education the same way they access equal measure of health. So those are the fundamentals as we discuss our health being. So where do we derive the authority to talk about our health? One, in our Constitution of 1995 for the Republic of Uganda, with the amendments therein, under Chapter 4, it clearly stipulates what our human rights and freedoms are, and Article 39 tells us that every Ugandan has a right to a clean and healthy environment. So it's enshrined in the Constitution. You have a legal right because the Constitution empowers that you should have it. When you look at our planning frameworks, the Vision 2040 clearly indicates that good health is instrumental to facilitating our socio-economic transformation. And therefore, unhealthy persons will not be productive to give us the GDP, the growth in terms of output that we require of a country. And so, what does the vision tell us? We should shift our interventions from being location or facility-based to household level. I am very happy that this gathering of the Third National Dialogue has brought in actors right from the subnational to the national level. Because then one of the challenges we've had is that we plan for people who are not in the planning meetings. And so therefore we are not able to ably represent their needs, their perspectives, their aspirations, and their future plans. Where else do we get our legal mandate to demand for good health? The National Development Plan 3, which is ending in next financial year that starts in July, clearly is a thematic group there under for health. Health of the human is one of the components under human capital development, wherein we have objective 3 that says that we should be able to improve the population health, safety, and management. I am giving you this legal background so that you know that you have a right to eat. You know that the documentation that we have actually speaks to it, and therefore, if you're going to be an advocate, it should begin with you, the adolescent. And then our leaders should take it up and ensure that it's mainstreamed in the planning frameworks, execution, monitoring, and reporting structures of government and systems that we use to implement our development plans, but also our annual budgets. You are not alone. East African protocols provide for the right to health in terms of biosafety. There is also an East African Health and Research Commission, and then we have an East African strategic roadmap on health. So when you come to the region, it is well catered for. Now, the World Health Organization, in its constitution, recognizes that everybody should enjoy the highest attainable standard of health as a fundamental right for every human being. And therefore, even internationally, it's recognized. So do not think that this is a dialogue that only focuses on Uganda as a country and all adolescents within your geographical space. The United Nations, in its articles, asserts that healthcare is an essential part and right to life. And so everybody in this room, everyone you've left behind, whom you're representing here, is entitled to that. So you can see from the legal frameworks, all from international to East Africa to Uganda, they are all contained in our planning documents. Why are we not getting sufficient support to push the human health agenda as per the international declarations, the Abuja notwithstanding? Let me give you the background. One, we have institutions that champion the provision, the planning, the execution, and delivery of our healthcare. We have a number of them. Ministry of Health takes the lead role, National Medical Stores for our medicines, National Drug Authority for its policy, blood transfusion services, Central Public Health Laboratory. We have the National Health Research Organization, the Natural Chemotherapeutics Research Laboratory. We have the national referral hospitals across the country. We have public universities that do health research, advocacy, and community outreach. And then we have local governments. That's why we have, even at the local government, we have a DHO, whose work is to supervise provision of health services within the district. I have a budget that would highlight for you all the institutions that now are categorized under the health thematic sub-program within the Human Capital Development program of the National Development Plan 3. They're about 65. And so, because of the programmatic approach, we do not want to have in isolation interventions that we will isolate and say the budget, and this I want to address to the CSOs. Please come, we give you accurate data for all the interventions that government is putting in under anything called health across the country. You will be surprised. I have the totals here for financial year 22-23, standing at 9.1. This year that we are executing and is coming to conclusion, it is 9.5. So therefore, when you say that it's declining, no, it is growing, albeit at a slower percentile. And so that is where we need to have engagement. We give you this data. Where you cannot access it from the website, please come to us, we'll give it to you. So that when you do your role as champions for advocacy, you do it from a better informed point of view than from outdated data. Now, what influences government funding, or what we are calling the key drivers for financial allocations to the health budget? First, let's have the composition. That funding to health interventions has GOU, which is Government of Uganda funding, through your taxes, which is 17%. That is relatively low compared to our peers. But you will also be surprised to see where it came from 5 years ago. It was lower. We have private spending. You and me, when we go to purchase, or when we visit a clinic or a hospital, and we pay for it. Those of you who are covered under your medical insurance by your employer, that is still under a business household, that accounts for about 41%. Do you know why that indicator is good for the public, especially for the economy? When we go to measure human capital development in a given country, we look at the proportion of the population that can afford access to decent health care. So in terms of development, like I will show you later, one of the reasons why we have moved from the least development countries, by the way, we've been getting a lot of grants, we've been getting a lot of external financing to support our health care. However, the economy has grown. We have left the category of least developed countries to medium developing countries. What that means, you should be able to sustain the interventions that you inculcate into your economy. And so we are going to see a decline in the grants, we're going to see a decline in concessional funding for health. Therefore, our leaders in parliament, our colleagues in the CSOs, we must devise innovative approaches to tackle the challenge of health. The other component, which has been our development partners through loans and grants, has 42%. It is dropped from about 56. That is a sign of development. The more dependent you are to somebody else for your well-being, the more underdeveloped you are. And therefore, since the economy is growing, we are seeing that proportion declining. Actually, in the subsequent financial years, we actually project it to drop further while the allocation from government rises. Now, there is one thing that is worrying though. Of all the total public investment expenditures, health only has 7.7% of our total public investment. Now we need our leaders to advocate for enhancement. We need our CSOs to advocate for enhancement and also those innovative approaches. Now, what is government doing? All the resources that you see allocated therein, allocated to about 4 to 5 areas. One of them is universal health coverage, where we go to our hospitals, referrals, health center 3s, health center 2s, and we are able to access medical care, which should be unpaid. That is one policy that government has been championing for the last 10 years or so, and so that is where the money is going. We are also seeing that we are putting a lot of resources into improving the functionality of our health systems. That's why you see refurbishment of Murago, refurbishment of our health center 4s, 3s, 2s, under the U-Gift program, under the GOU funding, under the HEST programs, that is supposed to increase functionality. It is also gone to enhancement of human resources. And that is why an intern now has a pay per month, which wasn't there. That is why your list paid medical doctor may be earning about 5 million and consultants earning from 10 to 15. Why? There was a lot of brain drain of our qualified personnel that were being attracted to other developed countries because of pay. You've seen, I think, for the last 3-4 years, that has been a priority for government. And then we have One Health approach, where we're addressing the zoonotic diseases, we're addressing antimicrobial resistance and biosecurity. Now, for the side of development partners, they have targeted interventions that they would require that government takes them up. So those depend on the development partner. We have over 30 development partners that support health, both on budget and off budget. What are we going to do? Since this is declining, since the economy has grown, and globally, once the economy has grown, you should rely on yourself. We should increase health revenue. How do we do that? We should diversify sources of government resourcing towards health. Among them, bringing on board cost sharing at our hospitals. Even though it is unpopular, that is one of the avenues that you should put on board, because you know, whatever pooling we bring will support the interventions that are currently in place. The other intervention we can do is to have a pooling of funds. And how do you pool funds? You accumulate them and prepare them for a particular category of the population. For example, if we see that our disease burden is in a given category of the adolescents, we earmark some funds for interventions within that category. We can also do tax earmarking. For example, I just saw a report this morning, over 70,000 deaths that were related to pollution levels in CBD and Kampala Metropolitan, Greater Kampala Metropolitan area. Mukono, Entebbe, Wakiso, Kampala. Now, if we inflict a discouraging tax, say for pollution, some of those resources should be earmarked towards fighting the ailment in the population. So that is something that you, the health champions, should be able to raise and advocate for, so that once it's taken as policy, we will know, like we did with NEMA, all the levies for the environment went towards NEMA. So how much should be able to go towards health among all the levies that we put in place? And then, of course, we should continue to dialogue with all actors of government to increase financing for the health sector as a proportion of the national budget. This, we know, should be moving in line with the declarations that government signed or ratified. What gains have we made in spite of the challenges that we have? One, if you are born today, the likelihood that you reach 68 years of age is 100%, except in circumstances where you choose unhealthy lifestyles and or where natural circumstances face you. What does that mean? Life expectancy has moved from 63 years of age to 68 in 23, 63 in 22. So now you are more hopeful to live for 68 years. Why? Because of the interventions that we put under health. The GDP per capita, this is the minimum everybody in the economy should earn in a given year, has moved to 1,146. That is in 2023, up from 1,081. Now, when we are ranking, that is one of the criteria that was used to migrate us from the least developed countries to a medium developing country. Now, for global level, our GDP is grown from 148 trillion Uganda shillings in 2022 up to 202 trillion in 2023. What this means that you and me are now more productive in terms of producing the goods and services that this country needs than previously in 2022. Why? Once you have been immunized, then you survive childhood. Once you've been given menstrual health and hygiene, then you are more productive. Imagine those days when you're not able to produce, therefore the economy loses your output. That is the implication of this, that we produce more. Actually, in the next 10 years, government has a strategy for growing it by tenfold. That means we'll be moving our economy from 50 USD billion to about 500. What is the implication of investment in health? Our maternal mortality has dropped by about 189 deaths per 100,000. Now, there was a time when this was about 1,000 for 100, but that for 100,000. So this is dropped drastically to 189. And also this, many of them are attributed to infrastructure, delay to arrive at the facility, options of going to the nearby facilities as opposed to going to a gazetted facility. We also see infant mortality rate has dropped to 29 per every 1,000. That means for every 1,000, we are losing about 29. We should ideally drop this in line with our national and international targets to less than 5. What are the lessons we've learned over time? Those achievements have been because of a compendium of factors which have been intertwined with interventions across the spectrum. One of them, we've set a very good foundation. That foundation is in systems for healthcare, is in structures, now up to Health Center 2, and with the PDM, we're taking it up to the parish. Once you have a structure, then you have delineated roles and responsibilities for everybody in the structure, as opposed to non-existent structures. What else have we done? We've integrated these programs. We do not push one agenda. Malaria, we say malaria for all. So we pick from a pregnant mother to an adolescent to a grandpa. So all of them should be safe, as opposed to saying we're pushing malaria prevention, mosquito net to only pregnant women. So we've integrated the programs. What has, again, government done? What we are doing here, community engagement, beneficiary identification, beneficiary education. We are here to dialogue. Listen to each other, listen to perspectives, hear where we've gained, understudy, where we have challenges, devise mechanisms of how we can improve that. And we've also had a try at results-based financing. If you look at like the U-Gift projects, they have parameters that influence the disbursement. If you do not meet the disbursement-linked indicators, that financing is given to somebody who is performing better. So we've given a try at result-based financing. If we can roll it more, we will widen. What do CSOs now need to do? Having identified those gaps, having listened to what has been done, having seen the reform, Having known where you're enshrined, one, we call upon you to keep identifying key areas. This could be human resources, and in human resources, identify the particular challenge. The Budget Monitoring and Accountability Unit at the Ministry of Finance did a study on the implication of enhancement of salaries, and they just piloted Naguru. There was an inverse relationship between the outcomes. One, we've also known salary increment alone does not increase or improve health outcomes. There should be a combination. So you, our colleagues in the CSOs, our leaders, should be able to highlight and say, while we put a lot of money into paying the people who deliver the health care, we have deprived the tools, equipment, accessories, and functionality of these facilities. And so we should have a deliberate effort to also ramp up interventions in those areas. So you should identify key areas, do your research, have your facts, do comparators with our neighbors and peers and those that we aspire to be like in the developed countries. Develop position papers on key thematic areas. Health is broad. Here we're discussing health for adolescents. If we disaggregate the health for adolescents, it's wide. So develop those position papers that should be able to influence policymakers, technocrats, the community to take up those thematic areas as areas for champions. What else can we do? What we're doing here. We build coalitions. I see a number of institutions here, peer-to-peer, Save the Children, AMREF, Plan International, Uganda Cares, and many others. Those coalitions give you a better bargaining power. They give you a block authority and give big authenticity to your advocacy. We should also continuously engage policymakers. Some of them are here. Some of them are here. Some of them at the level of the ministries, departments, and agencies. Others sit in cabinets, in the executive. Continuous engagement. Public campaign, what we are doing, both on radio, physical meetings. And then, of course, you cannot advocate for what you don't monitor. You should monitor it, you should evaluate it, and report. And don't only report the shortfalls. Please report also the successes, because they will enable us understand them and improve. Finally, I want to conclude by saying health remains a priority for government in its aspiration for a transformed society of Uganda from the peasant one to a modern, prosperous one by 2040. That action shall be done by you and me. Every stakeholder must take their part. The adolescent must get information, must have the desire to receive that information, analyze it, and devise mechanisms going forward. We must create awareness and engage all our stakeholders, including the beneficiaries. Then we must devise innovative approaches. Depending on the government alone, depending on our development partners, may not be sufficient for us to achieve our health aspirations. So we need to innovate. If we have green climate finance, what can the adolescents do to get some financing towards health? If we have a new innovative approach of big financing, what do we do to enable our health interventions achieve what they require to get? With that, I want to end there and thank you for listening.
Thank you very much, Mr. David, from Minister of Finance. Let's give him another round of applause. I hope we are still okay, because he was mentioning a lot of technical terms. I hope the adolescents and young people are understanding what the technocrats are saying in this room, because it's very important to be on the same page, because this is the same information we have to use as we are doing that advocacy and the engagement with our leaders at all the levels. On that point, where are the shifters? Are they in the house? Can I see the shifters, server children? Where are you? You need to energize these people for like 1 or 2 minutes, just 1 minute, so that we get back on the board. We dissolve those technical terms that we've just heard from Mr. David from Finance. And then immediately after that, we'll listen in from my namesake, Honorable Gafabza Muhumza, on the role of Parliament in terms of adolescent health financing. But as the shifters come in, I want to recognize the presence of Dr. Msira Timothy from the Ministry of Health. We are much honored to have you in the house, and we will be listening from you as we officially open at this event. You have strictly 2 minutes to entertain our guests.
All protocol observed. Good afternoon to you all. My name is Nale Masi from Namayumba Health Center 3, that's Waxo District. I'm a shifter. Many of you may be asking yourself, what is the work of shifter? Our dear guests, our work is to let our young people or our fellows to know about their life. We help them through campaigns, through different things. For example, we carry out community dialogue while talking about the teenage pregnancy. And that dialogue, by the way, has helped us to decrease on teenage pregnancy in Namayumba, because we had the aim and the objectives for that dialogue, and we decreased on 100%. We tried to decrease that teenage pregnancy by 20%. So we are going to have a song. Thank you for listening. We are requesting on another mic.
Ani asinga mbuza ani asinga
Sevuye singa.
ani asinga mbuza ani asinga mama
Sevuye singa.
ani asinga mbuza ani asinga
Sevuye singa.
ani asinga mbuza ani asinga mubagambe
Sevuye singa.
mama yabagamba nti sevu ebango mwali wanika wokwate muno tuwambera tuwanika abali bagoba abamala ne bawanika kano kenkube kachali mu kutalika mubagambe
Sevuye singa.
ani asinga mbuza ani asinga
Sevuye singa.
ani asinga mbuza ani asinga
Sevuye singa.
ani asinga mbuza ani asinga mubagambe
Wasese singa.
abali baloga amalogo yagafulula abali baloga amalogo yagafulula okuba layini teetagisalula teyesoma teterina namalala bebayogerako kimanye nti abo balala bebayogerako kimanye nti abo balala mubo bulamu basoka ku lukalala yajja kutuwonya boye eringa ddagala mubagambe
Sevuye singa.
ani asinga mbuza ani asinga
Sevuye singa.
ani asinga mbuza ani asinga
Sevuye singa.
ani asinga mbuza ani asinga mubagambe
Sevuye singa.
nange nvuddeyo ewakiso sevu njekwateko kubanga ebyobulamu boye mpaddeko sokolindeko nagezi kambalage mubagambe nti ani asinga mbuza ani asinga
Sevuye singa.
ani asinga mbuza ani asinga mubagambe
Sevuye singa.
ngenze omombalabirani kuba mukimanyi sevu yonnwanyi simpambanyi wabula meganyi mubagambe nti
Sevu yesinga.
ani asinga mbuza ani asinga
Sevu yesinga.
ani asinga mbuza ani asinga
Sevu yesinga.
enakitokolo mbuza ani asinga
Sevu yesinga.
ate wakiso mbuza ani asinga
Sevu yesinga.
eno naffe yesinga sevu yesinga ani asinga mbuza ani asinga
Sevu yesinga.
ene waffe boyi yesinga boyi yesinga ani asinga mbuza ani asinga mubagambe
Sevu yesinga.
ani asinga mbuza ani asinga ene waffe boyi yesinga enakitokolo boyi yesinga ate namayo boyi
Waffe
yesinga
yesinga.
ate magogo
Yesinga.
ate mashindi boyi ate wammwe
Yesinga.
naffe waffe boyi yesinga ani asinga mbuza ani asinga
Sevu yesinga.
enakitokolo boyi yesinga mubagambe
Sevu yesinga.
sefu ebango yali wanika wekwate mudu ne tuwombeda tuwanika abali bagoba bamala ne bawanika lengera feve na twawanika mubagambe
Sevu yesinga.
Thank you.
Thank you for your time. Save the children. We really appreciate. For real, for the work you're doing, you supporting, yes, for really the teenage pregnancy in Namayumba. Let me see one day, one time. It will be a history. Thank you a lot. May God bless you.
Thank you very much, the shifters. That was quite interesting. I was expecting some very young, energetic strokes, dancing strokes, but I missed those dancing strokes. Oh, okay. I was almost tempted to come and do the dancing strokes for the lead music artist, but on the next interlude. So, from that energizer, we want to now go back to the technocrats, to official staff. But before that, we've had more key officials join this important discussion. And I want to emphasize that the presence of these very important dignitaries is very important for the discussion we are having today, and having these relevant ministries, departments, and agencies in this discussion means a lot to the discussions of the young people. On that note, I want to request adolescents and young people to clap for all our officials who are here. It is a very good gesture to show that they are there for you and they are here to listen to your issues. Take them back to Parliament, take them back to Ministry of Health, take them back to Ministry of Gender, Ministry of Education, our funding partners here, I see UNESCO, and many others. So we don't take that for granted. Allow me, request Emmy, the members of Parliament here, just introduce yourself by name so that people know who is in the house.
Thank you so much. Good afternoon. Yes, we had plenary. I was a little late, but my name is Betty Ithon Alima. I represent this team, Wakiso District. I'm the woman MP there. Thank you so much. But I'm also part of the Parliamentary Forum for Youths. Then I'm also the Shadow Minister for Local Governments. Great seeing you once again. I used to be part of youth councils. That's why I can't give up with youth matters. Thank you.
Thank you very much, Honorable. The young people, you have your champions in the house.
Yeah, nice being here. Good afternoon, everybody. Said Nsamba is my name. I work for the Ministry of Education and Sports. I'm also coordinating the mental health and sexual support in the education sector. Nice being with you. I enjoy working with young people. Thank you very much.
Thank you very much. I saw Mr. Henry Semakula somewhere. He chose to sit with the young people, to have a chat with them. From the Ministry of Education and Sports, Mr. Henry Semakula, you're most welcome. I also saw somewhere Mr. Rogers Golova from Ministry of Gender.
Good afternoon. My name is Golova Rogers. I work with the Ministry of Gender, Labor and Social Development.
as a senior probation and welfare officer, and also work with young people. Glad to be here.
So you see, you have so many senior young people in the house. So you're most welcome, please.
Thank you. I'm Sebamala Richard. I'm a member of parliament for Bukoto Central in Masaka. Many of you are from up country. It is the place that housed the former vice president, Edward Chwandu Kasekandi. That's the one we replaced. He was getting old, so the youth replaced. The other, I'm happy to be here. I'm a member of the forum, the youth forum in parliament. We are past that, but we keep supporting and engaging in such discussions such that we can further your voice in parliament. Thank you.
Thank you very much. So on that point, allow me to welcome Honorable Muhumuza Richard to speak briefly on the role of Parliament in ensuring adolescent health financing. We hope we'll use a very few minutes so that we don't get into the lunch. Please,
Yeah, thank you. Because of time, I'll take the protocol that has already been observed. Colleagues, members of parliament, and everybody in your respective capacities. Once again, my name is Richard Gafabusa Muhumuza, member of parliament, Buamba County, Bundibujo district. Those who don't know, Bundibujo is at the extreme border, extreme west at the border with DR Congo in the mountains of the moon. The people from the mountains are short because you have to be down to earth. That's why I'm short. I am here to speak on behalf of the members of parliament. I know we are supposed to have the Honorable Dr. Yume, who is our chairperson, the Committee on Health. But we are the same. I will speak for all of us. Before I talk about our role as Parliament in planning and budgeting for adolescent health services, I want to make two comments. Number one, that the issues we are talking about, although we are focusing on adolescent health, they concern all of us, because all of us, apart from the adolescents now, but now they are part of it, all of us were once adolescents, all of us. But also number two, even when we are adults now, we have adolescents in form of our children and grandchildren, and we live with them. So the issues are our issues, we live with them. Point number two, and now that relates to what David mentioned here. First of all, David, I want to thank you for the very good presentation. When I was asked to speak, many of the things I wanted to speak, you have already talked about. I want to thank you for that. But I want to emphasize the point you made about the allocation in terms of budget to health. Many people, including civil society, who are involved in advocacy for health, they look at the budget for the Ministry of Health and say this is what Parliament or this is what government has provided for health in this country. And they pick that figure. Now when you pick that figure, previously you would be right, but currently you will not be right. Because we moved away from output budgeting, we are now in program budgeting. So for you to be able to pick, to get the actual picture of what government is putting in health, you need to look at it holistically in form of the program, the health sub-program. And David mentioned that you'll find this allocation in the Ministry of Health as the lead, but you'll find a lot of resources in the Ministry of Education. You'll find a lot of resources in the Ministry of Gender, Labor, and Social Development, because those are the implementing ministries and agencies therein that implement all our programs in the health sub-program. So for you to get, if you want to look at what is for health, you need to look for it in those areas, and then you can get the real picture. Like you said, now, if you look at the budget for this financial year, we are talking about 9.5 plus trillion. You cannot believe it. The other comment I wanted to make, now I talk about our role as Parliament. David, I want to slightly disagree with some of the indicators we have in this country in human. If you look at our Human Development Index, there's something you mentioned here, and this is my personal view, not the view of Parliament. If you say the percentage of the population that is buying medicine, that is paying for their health care, is increasing, and that is a good indicator in terms of human capital development, my personal view is that is misleading. And now I'm speaking as a representative of the people. Why is that misleading? In developed countries, they say the percentage of the population that is able, that can afford to pay for health care. Now, in our country, and especially for us who come from the rural areas, people are not paying for health care because they can afford. No. People are paying for health care because they have no alternative in the circumstances. Are we together? So, someone goes to the hospital, to the health facility, the personnel is there, but the medicine is not there. What do you want them to do? They will go and find a way, even if it means selling their property, to be able to get money to pay for health care. Now, that payment, in my view, if we say that such a number of people are able to afford, and therefore we are developing in terms of human capital development, in my personal view, that is misleading. Let us first have the medicine, and then people can choose. Because like now we have UPE, but there are people who are able to take their children where they are paying 5 million per term. Then you say people can afford when there is a free one. I thought I should make this statement as a people's representative. Now, Mr. David explained, and the explanation was very good. Now, in terms of our role as Parliament, in this case, it is appropriation and budget approval.
However, I wanted to begin with where David ended. As civil society, members of parliament, we need you to give us the information you are giving us. In form of policy briefs, in form of policy positions you'd want us to push. But most importantly, when you talk about these issues, please give us figures. Sometimes we talk about proposals and we don't cost them. And it becomes difficult for us as parliament. I remember there is a time there was a pronouncement of a proposal for government to provide free sanitary towels for girls in school. You remember? But nobody came up with the costing of that. Nobody came up with that costing to inform government, to inform parliament that if we take up that, this is what is going to take. This is the percent of the budget it will take. Now, this is where we have a problem. The process begins with our technical people in the ministries, departments, and agencies. By the time these budget proposals come to Parliament, they have gone through them in the ministries, they have gone through them at the level of cabinet, and they come in the form of a budget framework paper. These are proposals of government now. We look at Parliament. Of course, we divide into committees. We scrutinize these budget framework papers, looking at the aspirations of government for that specific financial year. I don't want to take the story long. Finally, it comes as a ministerial policy statement. However, when you look at the proposals, the aspirations, the priorities of government, and the reality on ground, I want to assure you that as Parliament, we get overwhelmed. Why? Because our current budget now is about 52 trillion. Next financial year, we are jumping to 72 trillion. But I want to assure you, if you look at the priorities of government for one sector, one sub-program, health alone can take the 72 trillion and finish it. If you are going to implement all the priorities of government, coming from all of us, civil society, the private sector, and all that, this money can go only on one sub-program. And yet we need to distribute this money to all the sub-programs. When you look at the international declarations and commitments we have made as a country, talk about the Abuja Declaration, the commitment, the percentage of the national budget that we are supposed to allocate on health, the percentage of the budget we are supposed to allocate on social protection, on education, on climate change, and all others. One time, we were in our committee, we were looking at those international declarations and commitments and the percentages of the budget. If we were to achieve all of them, we would have about 260% of the budget, which we don't have. Now, that affects us as Parliament. Now we begin looking at the priorities of the priorities of the priorities. If David shows you their budget we approved for this coming financial year, and look at the priorities they brought, the funded, partly funded, and the unfunded, you will find most of the issues we are talking about. Some of them unfunded. Now, this is where we get a problem. Even the finance people here, David will tell us, even agreeing on the meaning, grammatical meaning of appropriation becomes a problem. The understanding of many of you is that the role of appropriation is entirely for Parliament. They will tell you, David will come here and complain with his PSST that the Parliament is interfering with our figures. Because when we reach there, then we begin saying, no, the issues of adolescent health, this one you must put money. This one you must put money. But remember, we have a limit. We have the indicative planning figures within which we are doing all of this. So in summary, I agree with you. This is our role. However, as civil society, as development partners, you engage all of us, including even cabinet, even the president, by the way. Find time, if you can, engage the president, engage cabinet, engage parliament, engage all of us. But we must appreciate that collectively, now you are here, stakeholders, development partners in the health sub-program. That's what I will say. I want to tell you, you will go and also meet the development partners in the education sector. You will meet others in other sectors, and their priorities of priorities are also convincing, and you get stuck. You are like a family head who has only one chicken that you can afford, but you have a family of 40 people. And then you begin cutting a small piece to give each one of your children. So as a parliament, generally, we accept, and on behalf of colleagues, we accept all these issues, and we need to prioritize them. We need to continue engaging, because this is very key. We can play around other issues, but this is an issue for me, in my view, of human capital development, and that is the starting point. So we must prioritize it, give it the necessary attention in the form of allocation of the necessary resources. Because, for example, as they were mentioning here, we are talking about menstrual hygiene. If we don't give attention to that, the results of it are too much for us in the future. If these girls drop out of school, if these girls get early pregnancies, early marriages, and all that, then the rest of the things we are talking about cannot be achieved. I don't want to talk much. I wanted to talk generally, but I want you people to bear with us, and I want to call upon my colleagues, members of parliament, other policymakers, and even the implementers. But these are the issues we need to give priority, because they affect all other targets we are looking at as government. Thank you very much. May God bless you.
Are we too hungry? Let's give another round of applause. This is very important information, important commitments from very important people, and above all, our representatives. So we thank you for those remarks and those commitments. I'm sure at the end of this dialogue, we'll come out with that communique and those policy recommendations and other recommendations that will come to the parliament, they will go to the ministries, and we see how we take forward the conversations beyond this room. We are getting into lunch, and most importantly, we are also, when the Honorable Member of Parliament says a small one, I'll stay here near you so that it is that small like you said.
My times as a youth have always been to empower other youth to focus on very many things, but also focus on what they cannot do or what they feel impossible to see that can be made possible. But that's not it for today. I would want Minister of Education, just a brief about pads. Your budget reflected pads. And I want a brief, because I don't want you people to live here thinking that we never budget for pads. For the ladies, I see they are the majority here. They will think that we don't even care about them. The First Lady requested for pads, and we gave a very big budget. I think she procured pads that are almost half of this room. I think, you know, for me, I don't want you to go there and say Parliament is the bad one. Let the person in charge of health and mental something, if you, Saidi and Mr. Semakula, yes, please come to our rescue, because for us, we appropriate the money. And these youth are supposed to go knowing that this money was appropriated, but it was not enough. It was only made for maybe Western Uganda or the North, or we managed to give the people in Karamoja, but we gave out something. So we are thinking about you. So please, I want you to clear this now.
We are opening a very hot discussion in nearing lunchtime. We have panel sessions in the afternoon, and partly our officials are going to be part of these discussions, and they're going to share this information. And you can even fire them those big questions, because we want to leave this room today, this dialogue, when we have the right information from the right people, so that you know the messages you're going to use moving forward and what you're going to do. So, Honorable, allow me pack that to the afternoon sessions of the plenaries so that we can have a deeper conversation. And then we get into lunchtime. Ladies and gentlemen, I want to thank you for enduring with us. We've had the shifting schedules and programs, but we are nearing lunchtime. And very important is that we've had very deep discussions and important discussions from important people on the subject for today. At this point in time, we're supposed to have the Honorable Minister or State Minister for Primary Health Care to give the official opening of this dialogue. And before us, we have Dr. Musira Timothy from the Ministry of Health, who is here to make the official opening of this dialogue. We want to welcome you, and we are very much honored by your presence. You're going to officially open for us, and after that, I swear to you, I'm not going to invite anyone else. I'm not going to say any other word. Immaculate will take us to lunch. Dr. Musira, you're most welcome.
Good afternoon, young people, and good afternoon, honorable members of parliament. Now, after people have talked, especially members of parliament who know how to talk to the public, you may get disappointed about what I'm going to say because I'm not very good at public speaking. But I'll give it a try. I rarely speak to audiences. I only speak to a computer and a laptop most of the time. My name's Timothy Musila. I used to be a doctor. I used to be a doctor many years ago, just as I used to be an adolescent about 34 years ago. I work in the Ministry of Health, and I'm a policy specialist and health economist by training. Sometimes it's very difficult to talk after economists have talked. I know a little economics. I'm not an expert in economics, but I know a little economics, and I know the implication of some of the things that we do and say. I was instructed to come and talk on behalf of the Honorable Minister of State for Primary Health Care, Honorable Margaret Muhanga, and I asked her whether she was asking me to rehearse a future role, because I said, well, how can I go and talk in an audience where there are honorable members of parliament? I'm used to talking to them in committees, not here at this kind of rostrum. But I said I'll give it a trial. We are delighted as a Ministry of Health that these dialogues around adolescent health are going on. I think this is the third dialogue you are having, and you had some other discussions in the other two dialogues, and this is the third dialogue, and it is well attended. We are exceedingly grateful that you attended these dialogues. It shows the level of interest that the young people have in things that actually matter to them. A lot of times, people who have reached my age sit in offices and think that they will structure something that the young people will use. And the young people will always tell you, nothing for us without us. And what does that mean? That they should be part and parcel of the structuring process for all programs and projects that go on. And we should be able to share in the data that is produced, either on inputs, processes, outputs and outcomes, and probably also impact, so that they may be able to understand what role they are playing. I was happy with the Honorable Member of Parliament who talked about the investments that go into adolescent health, that they are across the Human Capital Development Program. I would dare to say that these investments are across all government programs, not only Human Capital Development. Why? Because all the outcomes you see in the health status of a population are an outcome of the investments that society does across the life course of its citizens, from birth to death, to cradle. So all these investments are really important for improving adolescent health. So much as we can focus on what investments we do as part of the Human Capital Development Program, we also need to interrogate the investments that we do in the other programs of government and what role they play in enhancing health in general, but in particular for this occasion, adolescent health. And I think that is quite important. I was talking to colleagues in the Ministry of Health, and I said, I think we need to start doing routinely in our national health accounts, we should be able to do an adolescent health sub-account and be able to explicitly bring out what investment within human capital actually goes to adolescent health. It's difficult because either by design, and I was part of the design many years ago, and I apologize for that, adolescent health has been subsumed under reproductive, maternal, newborn, child, and adolescent health. It's a mouthful. And what this means is that when you combine so many things into one, you tend to get lost in the sea. Doing the analysis to enucleate out the figures that you want sometimes becomes difficult, or sometimes people ignore that, they don't want to do it. And we've seen this being done, especially in resource-limited settings, because you do not want to produce certain evidence, because it will say, if you have this evidence, why aren't you allocating money to this? So I think we need to be a little bit more analytical within the Ministry of Health, those who will be there, so that we can understand this space of adolescent health and what we are putting in and what we are getting out with the involvement of the young people. And that would be important for us. We also need to appreciate the multidimensional nature of all the investments we do for improving adolescent health. So we have to look at what do other programs invest in what we are doing, and how does this contribute to the outcomes that we are able to observe. I like honorable members of parliament when they are talking about budgets. Budgets are important. A budget is just attaching a monetary figure to the things you want to do. Actually, budgeting is the end stage of the planning process. It tends to be much more emphasized in our societies. But for me to attach a budget to something, I should have done a situation analysis, I should have done a priority setting, I should have programmed, I should have done my priority rankings, and then I say, these are the things I want to do, and this is my priority ranking, and this is how I want to attach money to them. But maybe that is a bit difficult for us. We don't do it a lot. We try, but we don't do it a lot. Budgets are useful. When you are buying healthcare, what you pay for, that price is from your budget that you've been given. Unfortunately, what we pay for is not what we get. Price is what you pay, value is what you get. So I'm not very sure that in this country we are getting value from the investments that we are making across board. We could be able to extract more value from the current resources that we have if we could improve efficiencies, other things being constant. Sometimes there are tensions between efficiency and equity, and those tensions have got to be satisfied, and you do the trade-offs that are required to make sure that you are a bit more equitable. So sometimes in pursuit of equity, you end up paying more. But I think we can do, and as civil servants, as Ugandans, we need to interrogate the fact that we are not buying the value we expect to buy from the resources that we are allocated. And I think that is an important issue that needs to be interrogated. I think the other thing that would be important for us is to make sure that we have the data. You know, the theme of what you are discussing is innovative financing for health. Now, before you reach the level of financing and whatever innovations you want to do around those, you have to have the data that will convince people that you actually need the resources that you have to do, with the evidence that you, when these resources are invested, they can be able to generate the change that you are looking for. We did the landscape and, report. I think it was 2019. It's ending in 2025. So I'm asking colleagues in the reproductive health department that most of the data inside that report needs to be updated with current information as we move forward, because it's getting a bit historical. And once we have the data, then we can use it as a mechanism to talk to partners, to talk to government. The Honorable Member of Parliament has mentioned the importance of evidence in the members of Parliament sitting down and taking decisions about what needs to be done and where resources should go. So I think the onus is upon us as people working in these institutions to make sure that we generate the data that is required in an analytical form that is useful for parliamentarians to take decisions. And with no pun intended, you don't go to Parliament and tell them, you see, I have this Human Development Index and whatever. Some of them may not understand it. They need data reduced to the simplest form for everybody to understand. I'm very sure many of us here may not even know the components of the Human Development Index. Who knows what goes into the Human Development Index? Let me see. Adolescents. So you can see what I'm talking about. That it is important to produce information in a form that can be understood by people for purposes of making decisions. And I've seen sometimes we've been unfair to parliamentarians. We've produced policy briefs with information that cannot be very easily decoded. And then you cannot make decisions based on these policy briefs. We shall try as much as possible to ease the mechanisms by which we write these policy briefs to make sure that you can use them. Our appeal and the appeal of the Honorable Muhanga to this meeting is that the young people should always know that you are our allies. That's why in the governance structures of the Ministry of Health, the so-called technical working groups, the young people are represented. They come and represent and they say out what they want to see. And we have a technical working group that deals almost exclusively with adolescent health. But we are appealing to the young people. How long you will live and the quality of life you will have when you reach my age will depend very much on the investments you do in yourself at your age. In behavior, in skilling, in lifestyle, and in the way you plan your economic upbringing. A lot of times when people talk about adolescents, they think you are changing physically, physiologically, and psychologically. Many people tend to ignore the fact that you are also changing economically from being a dependent to being depended upon. And that is something very, very important. Let me tell you, economic success contributes a lot to health and well-being. Don't let anyone tell you lies. So it is important from childhood. The behavior you have when you are still an adolescent will determine how you live in your 40s and 50s. And it's very important that you think through that. So that was the message that I was asked to bring. I'm not very good at speaking, but I hope you've picked something from the delegation that I was given. I'll try and train myself to speak publicly. Maybe next time my delivery will be much better. Thank you very much. And on behalf of Honorable Margaret Muhanga, this meeting is open for the dialogues that you are going to have. Thank you very much.
Thank you, Dr. Timothy, for those opening remarks. They have been really wonderful, and we pray we put them into consideration. Thank you very much. Right now, I want us to go for lunch. And we are going to have our lunch at Royal Restaurant down at the ground floor. For those of us who don't have coupons, you're going to get your coupons from Grace. She's just right there behind. And before you go for lunch, we are going, allow me call upon Reverend Nathan Mugalu to lead us into our prayer and as we walk out for our lunch. Thank you.
May we humble ourselves. Lord, our Heavenly Father, we thank you for this time that you have granted unto us. And Lord, we thank you that from morning you have been feeding us with information and knowledge. Now, Lord, as we go for lunch, we pray that you may bless it and sanctify it, that once we partake it, we may get more energy to come back in the afternoon and do our roles as we came here. Lord, we pray for the afternoon session, may it be filled by your Spirit. But above all, Lord, we pray that we may get tangible results out of this dialogue for the betterment of adolescent health. In the name of the Father, Son, and the Holy Spirit.
Ladies and gentlemen, before you leave, in case you've come across 2 keys, there are 2 keys just on a holder. Please kindly forward them to us. 2 keys. Somebody has lost them. Very important. If you come across 2 keys, please give them to us. We are requesting that we resume at exactly 2:45. That means we have an hour for our lunch time because we have more discussions to finalize in the afternoon. So let's see each other at 2:45. Kindly, if you see those 2 keys, please forward them to us. Thank you very much.
Snapchat. Bila kwa neno. Aha.
Yes. Now, yes, as you are seeing, and at least a good one. First wait, I'm taking. Uh-huh. Make it like this.
Kubanga kano ke kasinga okubeera kalungi. And make sure I have that.
Angishakwazi nokulala. Darling, nami ngikukhumbule. Wena darling, nami ngikukhumbule. Say yes. Would you say yes? Say yes. Say yes. Oh, I need somebody to just come out and say yes with your heart. Oh, yeah. Oh, come on, shout it loud. Say yes, I agree. Say yes.
ngivumele ngithande ngizokuphatha kahle ngiyacela ungethembe ngizokunika lonke uthando hayi ngivumele ngithathe ngivumele ngithande awungizokuphatha kahle hayi ngiyacela ungethembe ngizokunika lonke uthando hayi angizenzi idalo nami ngethiwa uthando inhliziyo ayiphakelwa ifuna emfunayo mina ngifuna wena wena wedwa sandela wena wena wedwa angizenzi idalo nami ngethiwa uthando inhliziyo samba nelikapondo vele liguqule nengqondo yeah wayidlala inhliziyo yeah wayibhula inhliziyo yeah wayidlala inhliziyo we wayibhula inhliziyo imali eloto yaphela imali yami yaphela imali yami Lord imali eloto yaphela imali yami yaphela imali yami Lord imali eloto yaphela imali yami yaphela imali yami Lord imali eloto yaphela imali yami yaphela imali yami Lord ingadlala adlala ilotto nawena beza amantombazane ngingathatheka mina benginganje ngingadlala adlala ilotto nawena beza amantombazane ngingathatheka mina benginganje
Excuse me people, this is DJ Ace.
sagcwele ukudlala. Ebuye ekhaya, uye ekhaya. Ay, 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 ay. Athi wena, wena, athi wena,
Hello, hello. Welcome back from the lunch break. Are we back fully or we are still networking? I want to request us to be back fully so that we do the afternoon sessions and we see how we wind up the dialogue. So, ladies and gentlemen, I want to welcome you to the afternoon sessions. DJ, keep that in the background. So, we previously had a lot of sessions from the politicians, technocrats, policy people. We want to feel the vibe of the young people. So we want the young people to be the ones to begin for us the afternoon sessions. And the DJ is going to help us have that vibe of the young people as we usher into the discussions for the afternoon. So if you know you're a young person in this house, please demonstrate and show us that you are still young, energetic, and you want these people to listen to you and address your issues. So DJ. So young people, where are you? We don't see you. Get up, get up, get up. Where are the young people? You want me to point at you? If you know you are young, stand up and listen to what the DJ is doing. DJ, first stop. DJ. I want to promise young people that if you don't stand up and show yourselves, you are not proceeding with the afternoon sessions. So follow the DJ and show us that you are ready for the afternoon sessions. DJ, there you go. Is this how you do it, young people? No, the platform is yours. You can go anywhere, in front.
Each and every lady wanna give me when they smoke weed, when they smoke cigar. Now we there, I tell them
Should we close the dialogue? We are done. Where are you? You have only 3 minutes. If you fail in 3 minutes, we close the dialogue and go home. Go on. DJ, proceed. They have only 3 minutes.
Yo, alright. Bing, bing, Ogo baya. Bing, bing, bang, bang, baya. Bing, bing, Bista. Oh, boy. Kanogo masonsasi. Ofumita ufumi sati masonsasi. Kugambe mafonsasi. Oh, Zambe. Sifulai, yambuza kuhemalira. Oh, Zambe bizibu byo byemalira. Me, embuzi zekabya. Embuzi zekabya. Me, ajiwe yesoza. Ajiwe yesoza. Shipula, when I'm sending a kirira. Nakute fene kwa sike miula. Oh, Zambe. Oh, Zambe.
era nze tonyambula ozinanga omulala ow'omala kwekubya byakunywa muti gwe woolina mpenkoni wayiga maze nokufumita masonso
Thank you, DJ. Thank you. Thank you, the young people. Thank you very much, and we want to welcome you to the afternoon sessions. Welcome back from the lunch break, and thanks to the young people for showing us the energy. I hope the room is energized to proceed with afternoon sessions. We'll have very few speakers for this afternoon. We have been already challenged by time, but you're sure that we shall still end in the appropriated time, or even before the time that we have on our program. We want to again welcome our dear honorable members of parliament who have joined us later, the relevant officials from the different government ministries, departments and agencies. You're most welcome. All the protocols observed. So we are going to get into the afternoon sessions. The sessions will be opened up with one speaker who will take 3 minutes to share some insights. And immediately after those 3 minutes, we will get into a panel discussion. After the panel discussion, we'll have plenary, and we get into the closing ceremony. So while earlier we had anticipated 3 panel discussions, that's not going to be possible. We'll have only one panel to discuss the various issues. But before that panel, I want to invite Mr. John Ampele, from the Principal National Program Officer from National Population Council, to use 3 minutes to share with us some insights. The way you're looking at me, we are really challenged with time, but use as few minutes as possible so that you usher us into the panel.
Good afternoon, ladies and gentlemen. I'm very happy to be here. And as one speaker said before lunch, a number of years ago, I was like you. I wasn't born the way I am. Ladies and gentlemen, we were called upon to talk about the demographic realities through the life course and their implication towards improving the adolescent health indicators for Uganda. And because I have been given limited time, I want to start as the presentation is being projected. I want to say that when we talk about the life cycle, we are talking about the entire continuum of life, which begins before conception. Many times when you talk about life in Uganda, we tend to begin from birth. We tend to calculate 0 and above. But if we want to have a quality kind of population, it begins with the preparations for conception. Ladies and gentlemen, there are a number of services that are required to make a wonderful young person at each of the stages, as we shall be seeing. And ladies and gentlemen, if we miss out on one of the stages, you are not going to have the quality kind of person that you would want. That is why in health they will talk about nutrition, in education they will talk about early childhood development. There are a number of factors that affect who a person becomes. No wonder you'll find some of the districts, we have people who cannot be compared with people in other districts because of the different advantages, opportunities that these people have been exposed to. I would have wished to show the population of Uganda and how it is distributed according to age and sex. Yeah, but when it comes on, we shall be able to see it. But important for us to note is that most of our people are young people. And so Uganda, as a young country, is supposed to be changing the way we project, the way we plan towards looking at young people. Because if we planned for young people, we would automatically be planning for everyone. We have a huge young population, and the main reason for this youth or young population is our total fertility rate, the average number of children a woman can produce within her reproductive age. And this has been high. Demographically, every total fertility rate that is beyond 4.2 children per woman is considered high fertility. And in Uganda, our fertility has been above 5. When the 2022 results of the Uganda Demographic and Health Survey were released, it showed that we are at 5.2 children per woman. And this is very high for us to be able to achieve the benefits of our population. And what does it come with? It comes with high dependence. It comes with challenges to do with unfavorable structure. Because when you look at our structure, had I seen it? So if you look at our structure, you realize that about 40% of our people are children who are not productive. And what are they requiring? Services for them to be invested in so that we can achieve the benefits of this population. Ladies and gentlemen, I want us to understand that if we are to benefit from this population, we must timely reap the advantage that these young people offer. Because if you are not able to reap that advantage, you're going to miss out. We talk about harnessing the demographic dividend, but for us to harness the demographic dividend, we must be able to invest within this population. You cannot harvest where you have not invested. So if we are talking about improving the indicators of adolescent health in Uganda, how much investment have we made for us to be able to benefit from them? We can be there lamenting that our population is of a poor quality, but what have we done to ensure that this population is important? For us to benefit from it, this population is supposed to be healthy, it is supposed to be well educated and appropriate skilled, it is supposed to be productive. And this productivity comes with a number of advantages that result from a number of investments that we have made. So it is important that we consider investing within our population. I seem to be failing to get the presentation projected, but can I project using this computer? Okay, so ladies and gentlemen, if we talk about the demographic realities, I took time to break down our population according to age. 43.6% of our population are children who are aged 0 to 14. 43.6%. And as I said earlier, these are children who need services. If they don't get these services, they are not going to be productive as we would wish to be. But when you look at those children who are supposed to be in school, considering 0 to 8, where we have foundations for human capital development, you realize that 30% of our population are below 9, 0 to 8. This population is supposed to be groomed. They are supposed to access early childhood development services. And in 2017, according to Ministry of Education and Sports records, it was only 16% of girls and 14.9% of boys who were able to access early childhood care and services. That shows that the majority of our people are just left there. They are not groomed the way it is supposed to be. Looking at those ages who are supposed to be in primary school, 6 to 12, our population has 9 million children who are supposed to be in primary school, and that is 19.3%. What do we need? We need to ensure that these children are in school. If they are not in school, they are definitely lost. I think we had a foretaste from COVID-19 when the schools were locked down. A number of challenges affected our children, And up to now, those who are in community work, you still understand that there are those who dropped out and have not yet had an opportunity of returning to school, maybe due to teenage pregnancy and other factors. And in 2017, only 52% of the boys and only 54% of the girls were accessing primary school. So if more than 40% of our children who are supposed to be in primary school are not accessing primary school, how do we intend to benefit from them? How do we intend to ensure that they access services, they deliver from the whole health facilities, how do we improve these adolescent health indicators? It begins with us investing in them if we are to benefit from them. We also have those who are supposed to be in secondary school. Just a second, let me pick something. So ladies and gentlemen, I have already talked about this, our distribution according to sex and age. I've already talked about the issues of fertility, and this total fertility rate is distributed across the entire country. There is no region that says they are not doing badly. We are all above 4.2 apart from Kampala. And because of that kind of fertility, this is the structure of our population. And on my left, we have the population structure of our country, which is bottom heavy, and we are working towards achieving Vision 2040 with the population structure as you can see on the right. And I have already said for us to benefit from it, we must invest in it. And I was talking about this when I was saying, when you look at the different demographics of our country, it calls for us to sit down and think how we can invest, because each of these categories has got services that contribute to the betterment of the kind of young people and adults that we are looking out for. And we realize that adolescents that we are here for today are about 11.3 million people, and because they are 11.3 million people, it is important for us to think of how we can work towards improving their services. Ladies and gentlemen, if you look at adolescents and young people, they make over 34% of our population. And so since this is the majority of our population segment, it is important that actually we stop involving them in planning, but we concentrate on planning for them. Because if we concentrated on planning for this category of people, we would be able to have a productive youthful population, which is about 11.4% as we speak, 2024, and we would address a number of challenges. The dependence burden is still our main problem, because as we can see, about 31% of the population is supporting the entire country. And I am considering this because in our country, productivity begins at around 25 years. Before 25, many of the people are either in school or they are still trying to see how to survive. And because of these challenges related to our demographics, we have poor indicators. And one of the indicators is that while 99% of our people are delivering from or attending antenatal care, only 86% of them deliver from the health facilities. And this is where we need to understand that most of the young people do not go for antenatal care, and if they happen to go, they don't deliver from the health facilities. Because sometimes they are not ready, they are not aware that their time has come, they are due, and sometimes they are not well facilitated to access these health facilities. And so the biggest percentage of the people who deliver out of the facilities are these adolescents. It is important for us to think of how can we address such an issue to ensure that they have an opportunity to deliver from facilities, if at all they are to deliver. The fact is supposed to be, young people are supposed to be in school, until a time comes for them to deliver. 40% of our women and 11% of the men who were aged 20 to 49 during the DHS 2022 were already in union by age 18. So we are talking about early marriages. So such kind of marriages will call us to ensure that we see how to address issues that affect these young people. If we do not sit and address these issues, teenage pregnancy will continue to increase. Teenage pregnancy related to early marriages. And this is going to affect the indicators. Uganda has tried to improve, but the indicators have been bad just because of challenges like these that we face with young people. If you talk about issues of child well-being, you realize that we still have stuntedness, and most of those who are stunted are children who are born by teenage mothers. I am rushing through because of time, ladies and gentlemen, so that we can continue. But the indicators are showing that the situation is bad. I have already talked about issues of teenage pregnancy. It has stagnated, and many of you who are working in the communities know that it is affecting everybody. It is regionally distributed. There is no district or local government that can say for us we are not having teenage pregnancies. It is a challenge. In 2021, we tested a number, and we realized that there are regions that are leading, regions like Busoga, regions like Lango, regions like North Central. North Central, this is part of Buganda, by the side of Mubende and others. These are leading in teenage pregnancies. When it comes to indicators like antenatal care, young people do not access such services. When it comes to mortality, we know that most of the maternal deaths are actually contributed by teenage mothers. 28% of maternal deaths are from teenage mothers. While for infant mortality rates, 20% of infant mortality rates are from children who are born by teenage mothers. So ladies and gentlemen, as we move forward, it is very important that we consider responsible and age-appropriate sexuality education. We consider age-appropriate reproductive health services for these young people, so that we see a way how we can improve the adolescent health services. It is important for us to invest in a quality, universal, and compulsory education. An education child is an informed child. If you were to look at those teenage pregnancies, majority of these are from children who are not accessing education. It is important for us to think about providing information that is not biased, free of myths and misconceptions. And so we need to come up with programs that are targeting specific categories of people. Sometimes they could be religious leaders, they could be parents who are opposed to some of the services that are meant for young people, but also they could be politicians. Thank God that we have those who are here who are champions. But they could be political leaders who are opposed to such services. We need to target them. Whether we are implementers, whether we are funders, whether we are government, this is the way to go. We need to address issues of enabling environment, issues of policy, so that those who are offering services offer services without any form of fear. And ladies and gentlemen, lastly here, it is important for us to empower these young people economically. Those who are becoming pregnant because they are in need of money. They are in need of a service. They are in need of food. If they were able to work for themselves, they would not be able to be seduced by young men who would impregnate them. Ladies and gentlemen, 41% of our population of youth who are aged 18 to 30 were not in education, they were not in training, and they were not employed. So 41% of our population, I should say, of young people is lost. So if they are lost, when will we ever catch up with them? Do we get surprised when we see kicks flying around Kampala? It is important, ladies and gentlemen, that we shift our planning as one of the takeaways from this dialogue to focus on young people. Let us make the young people the center of our planning, the subject of our planning, so that we are able to address their needs, but also able to unlock their potential. If we do that, we will be able to change their indicators. Thank you so much for listening to me, ladies and gentlemen.
very important information for this gathering, but also future interventions and engagements to take forward the discussions around ensuring adolescent health. We want to move to the next session, and this is going to be a panel session. We'll have a few speakers, like earlier communicated. We have collapsed the 3 panels into one because of time, and we'll ensure that we benefit from the one panel discussion we're going to have, and later on have a plenary and the closing sessions. So we request you to bear with us. So I want to invite our dear panelists to come and take these, I don't want to call them hot seats, but they are very good, comfortable seats. I'm sure you're prepared for this. Whoever is holding Reverend Nathan Mugalu should release him, because I need him to join the panel. Ladies and gentlemen, allow me to welcome Reverend Nathan Mugalu as our first panelist for this afternoon session. Please, take a seat. Our next panelist is going to be Mr. Henry Magala, the Country Program Manager for Uganda Cares. You're most welcome to the panel. Our next panelist is Owechitiibwa Nkenga Sam Nathan from the Ministry of Agriculture, Busoga Kingdom. You're most welcome to the panel. We have Mr. Said Samba from the Ministry of Education and Sports to join us. Please welcome our panelists, because they are going to share with us very important information. Our next panelist is Dori Ajok. She's a project manager from AMREF. Please welcome to the panel. And lastly, we'll have Ms. Namtebi Maureen from Plan International. Please welcome to the panel. So for purposes of time, we'll ensure that we use the remaining time as sufficiently as possible, but also ensure that we benefit the best out of this discussion. I'll request our panelists to respond in time, and then we'll give time for plenary where you have comments or any points of clarification. So, our dear panelists, you're most welcome. And this afternoon, we're going to have a deep conversation stemming around adolescent health, and our theme still stands. But since you are from different perspectives, we'll have different insights from the sectors you are serving in. And I want to begin with Reverend Nathan. You are very instrumental. You're a champion of the adolescents, so-called senior adolescents. And we want to hear from you on the role of religious leaders in advancing adolescent health and programming in this country. We welcome your insights.
Yes, good afternoon, dear team. I'm excited to be here this afternoon. Reverend Nathan Mugalu, a senior adolescent, but also one of the champions for adolescent health. One of the greatest African theologians called Tom Mbiti once said that Africans are notoriously religious. I want to believe that all of us in this room are notoriously religious. We believe in some sort of natural super being that pushes us in most cases to spiritualize everything of our lives Therefore, since we are religious, in most cases, religion is also a function of culture. So, such a question, the role of religious leaders in advancing adolescent health, it is actually very instrumental because adolescent health is a function of community dynamics. And part of the community gatekeepers and shock absorbers are the religious leaders, depending on which religion you actually come from or you subscribe to. These are some of the things that religious leaders do or should do in order for adolescents to have health that can be called health. First of all, providing safe spaces for religious institutions to be safe havens for all young people to thrive. I mean, a young person with any challenge in health, in gender, mental health, sexual health, maternal health, should be able to find safe haven in either church, a mosque, I won't say shrine, but providing safe spaces. But also religious leaders are actually epitomes of information. But the question is, in most cases, which kind of information do religious leaders provide, especially to do with adolescent health, especially things that do not match specifically very well with some of the religious beliefs. We call that religio-scientific integration. So part of their role is to do religio-scientific integration, to appreciate scientific facts, but also to appreciate data, and then see how we can integrate religion into science, into public health, into sociology, psychology, and other forms of health. Then the other issue is behavior change. You realize that adolescent health, in most cases, is a function of behavior. Whereas when behavior is inversely proportional to what is expected, adolescent health will worsen. Where behavior is okay, then adolescent health will blossom. So religious leaders are in charge of behavior, and that is behavior change communication, because I'm very sure that you know that we are the only people who say things that are considered biblically true and are not challenged. So when religious leaders mention things to do with behavior change communication, then that's a very great role. Definitely service delivery through the different institutions and everything. But the question remains, the religious leaders that are supposed to do all this work, are they going to give us what they don't have? The question is definitely no. So they can only give us what they have. They can only give us in knowledge. They can only be our partners in information. So religious leaders breaking myths and misconceptions that worsen adolescent health. The gender stereotypes on disability, stereotypes on menstrual health, stereotypes on mental health, stereotypes on maternal child health. This can be a good contribution. Then male involvement. You realize that much as in some cases male involvement does not come out very well, but it's the job of religious leaders to make sure that boys and men are eagerly, actively, but also purposively involved in issues of adolescent health. As religious leaders, we are the people that have authority over men and boys, because we have the authority to talk to them and challenge them on any issue without backfire. So male involvement is very key if we are going to achieve general adolescent health, but also religious leaders contributing to the general health. Maybe lastly, acceptance. Quite a number of adolescent health issues have not yet been fully accepted into religious spaces due to probably maybe religious beliefs, maybe sometimes due to alternative beliefs. So in most cases, religious leaders have a job to accept some of the dynamics of adolescent health, to appreciate the uniqueness of adolescents, to appreciate the speciality of adolescents, and then respond to their different health needs as they come. So acceptance is very key through integration. Thank you.
Thank you very much, Reverend Nathan. Before you pass on the mic, you mentioned a very key issue on acceptance of the dynamics of adolescent health issues. In most cases, we hear the church or the mosque say immorality. and most of the issues they are considered immoral. How do we change that narrative to ensure that we embrace the adolescent issues?
Well, part of the principles of smart advocacy, like I've already said in our spaces, during our time when we were still very vibrant and young and energetic, we used to do activism. We used to do a lot of, you'll bear with me, noise making. But of late, we changed. We do smart advocacy. We do intentional advocacy. We do objective advocacy. And we do calculated advocacy. Now, some of the issues are considered immoral. Yes, we agree with that. But the question is, and I've already said this, what aspects of adolescent health can religious leaders contribute to according to their expertise and according to their specialties? So, some issues, yes, you'll find, oh, yes, these are immoral and whatever. But we have three dynamics of adolescent health that are not actually only immoral. Number one, we have the biomedical approach to adolescent health, where we find so many contentious issues on adolescent health. Then we have the behavioral approach to adolescent health, where religious leaders have a specialty and where they have a niche of contribution. Then we have the structural approach to adolescent health, where we have government, policy, leadership, and all these things. So, finding a middle ground on where we agree, but also where can everybody contribute. There are people that are free discussing biomedical approaches towards adolescent health. Now, if religious leaders are not as free as we wish them to be, but they can freely discuss behavioral approaches to adolescent health. So the question is, we are not going to win over everybody. That's a fact. At least, why am I a senior adolescent? I am a senior adolescent because I have accepted that some people are not going to change, but they can contribute to the cause in their uniqueness, but also in their specialty. That's why I'm still a senior adolescent. I have not decided to get old and age and die of depression because the other people are not going to accept what you're talking about. But they have a contribution. Are they contributing to the biomedical approaches towards adolescent health? Are they contributing to the behavioral approaches towards adolescent health? Are they contributing to the structural approaches towards adolescent health? So when you find the niche on where everybody can contribute, then you'll find that we shall have collaboration, integration, but also comradeship in the struggle towards achieving holistic adolescent health and in the struggle to find that every young person in this country can live holistically, develop holistically, but also achieve their full potential. Thank you, sir.
Thank you very much, Reverend Nathan, for those insights. Picking from that, Mr. Magara, we know Uganda Cares has been at the heart of HIV prevention and care, and you understand you've taken quite deep initiatives at grassroots, national, and regional level. We want to pick from your insight in terms of how do you think we can engage adolescents more, especially adolescents living with HIV, in the programming for their health to achieve their outcomes.
Thank you so much, Chair. Civil society organizations have done, am I on? Okay, good. So there's quite a lot that we need to do with young people living with HIV. HIV is a long-term condition. So one of the issues that come around is anxiety that comes around when a young person finds that is has HIV. So issues of stress, issues of emotional and mental issues arise. So as civil society, one of the critical intervention has been counseling and guidance to ensure that they accept the situation and live with it positively. Another thing that we have done as civil society organization, I think kudos to peer-to-peer, because we are here because of peers, the work that they do. So the peer approach has done quite a lot. We have developed leaders among the peers who are able to share their experience and mobilize other adolescents that are living with HIV, to live positively with them. So peer approach has been a critical intervention that has worked. And our senior adolescent has talked about safe spaces. They have done wonders. As an organization, we see young people coming up and sharing their experience, and even moving out to share their experience, to challenge even policymakers to do quite a lot that needs to be done. So that has been critical. The area of advocacy is very important, and we have seen this happening. We are aware of SEHAD experience going to the court to ensure that we have a policy on sexuality education. And so advocacy has done quite a lot, and with that, we have been able to provide the basic, SRH services to the young people that are living with HIV. And then another thing has been community engagement, as it were, mobilizing the community to accept the status of the young people, and that begins with the family. We're in a situation at a time when, instances are there, when one is found positive, receives a rejection from the family. So that's another area that we have done. And then again, I think one of the presenters talked about, the population chief talked about poverty. It's an issue. And so as civil society, I think that's an area that we have looked at, ensuring that the young people get a skill to be able to get a livelihood and be able to fend for themselves. So that has worked very well. And then, of course, the SRH, I've talked about that. Can they have access to prevention methods, especially when it comes to, am I ready to get a child at this time? So that has been another area that we have looked at. So access to treatment is very critical. And as an organization, one of the issues that we saw, I think in 2016, was that increasingly we are getting young people who are not living on drugs. And that affected their healing process, their positive living with HIV. So adherence has been one of the interventions that we have worked on. I submit.
Thank you very much, Mr. Magara, for those insights. As you pass on the mic to Owechitiibwa next to you, we know that culture is a very huge pillar in terms of upbringing us from childhood to adolescenthood, even to our mature age. And we believe cultural institutions and leaders have a great role in terms of ensuring that adolescent health issues, including financing, are well tackled. So we want to hear from your perspectives as a leader from the Busoga region. Do you have a budget, first of all, in your kingdom for adolescents in terms of their health issues? And how can we push for more financing to address the challenges facing adolescents?
Thank you very much, moderator. I'll first introduce myself properly. I'm Owechitiibwa Nkenga Sam Nathan, the Minister for Agriculture, Animal Industry and Marketing in the Busoga Kingdom. And at the same time, I work with the Scale Up project with Amlesh. And I have an organization which gears itself towards GBV prevention, and also it has hands down on the youth and the adolescent. In relation to what you have asked me, first of all, I want to inform this House that cultural institutions are the first leaders before the coming of the Europeans in Uganda. The Europeans came when these institutions were there, and they were having the administration and their leadership, right from the grassroots up to the kingdom level. And as regards to Busoga Kingdom, our king, His Majesty Governor Diop IV, has a special aspiration, and he puts more effort on the youth and the adolescent. And I want to assure you that he has been put up as someone who is a model person in this Uganda as regards to youth, GBV, and the like. So meaning that Busoga has a big task, and which is very practical, to see that we curb down all aspects that deter the development of the younger generation. In our program, which I can share with you, we have 3 ministries which are directly responsible for the adolescent and the youth. We have the Ministry of Gender and Social Services. We have the Ministry of Youth, which is directed with these younger people. And we have the Ministry of Health. And they are working together, and they have developed a paper whereby they are tackling the issues right from the grassroots. They go up to the Chisoko, that is the lowest person, to the family level, to see what are the challenges as regards to adolescent and the youth, which are making Busoga not develop at a very high speed. And in so doing, we have decided and have instituted a number of policies which are being instituted to see that we can handle. And one of them is the financing aspect. And in the financing aspect, we are giving special attention to address the challenges which have been got on regard to adolescent health. And in that, we are working closely with the Ministry of Gender, Labor and Social Services to see that there is some money apportioned to try and work on these issues. And also our line ministries have run very fast, and they are getting some partners, and Plan International should be one of them, and I'm happy to see them here because they are handling it with the Ministry of Gender to see that we all have a Chigango cha Busoga, whereby the youth, the vulnerables, are put for a retreat to see that they can have a change in mind setting, and also learn practical issues that can bring some money. We thank you very much, Plan International. And at this time, we are bargaining with the AMLEF to see that they come on board and work with us to ensure mostly on the teenage pregnancy and school dropout, which is very rampant, as other people have said. We are taking our first source of income is the family, the parent. That is, we are using that one as the first income, which can help to fight this, whereby you very well know that it is a right for the child to have education, to have good health and the rest. Therefore, who is responsible for that? It is the parent. So the parent is supposed to take up his roles to ensure that he nurtures this child in the Chisoga way, whereby we protect the values, beliefs, and customs that are good from Busoga to this child. Because I want to assure that in Busoga, a child was not supposed to get married, even to be pregnant at the age of 13 to 19. He's supposed to go to get married from 20 onwards. And we used it to say, Ntinga amabere gamaze okuwola. When she has those, how do you call it? The breasts have gone down, have bent down and they are ready. So that one is ready for the man and ready for the child. So that we fight that one directly to see that these children don't go for such issues and get early marriages and early pregnancies. So we start that. With that, then we look at the culture institution itself to have a very big across the kingdom to make sure that they sensitize the communities and see that this need is handled effectively. So there we are using the local, available, affordable resources. That is the human resource. And then we are looking at collaborating with other agencies, as I talked of Plan International and AMREF, to see that we can come together, plan together, and where possible, pull resources together and do these activities to assist the adolescents to see that they can grow up into good Ugandans in time to come. Then we are engaging, and you have already started that, we engage the districts and the central government on policies which is that they are not really good, to see that we can put in our input to see that those policies are done very well and they are accommodative to the juvenile. And that one can help us also in soliciting the funds from other people. We have also tried to get other people who can help us to see that they can train these younger men. And are they men really? They are not men. These younger girls and boys, I'm humbled to use that, in entrepreneurship, to see that they can start getting something. Because we know that lack of and poverty in the home and the children themselves, that is what is inciting them to go for those other bad habits. So we are trying to have entrepreneurship trainings for both adolescents and youth. And also we are visiting schools, and through the education ministry, the schools have special programs that can engage these boys and girls to see that they can understand and have a mind setting. Also, we have established a skilling program whereby through our partners, we are getting every now and then to see that we get some resources, and those resources can be used to skill these younger girls and boys. Our values mostly, they hinge on no early marriages. That one, when there is early marriage, that is a taboo in Busoga. Child neglect by parents, that is another taboo in Busoga. Equal rights to children, that one has been adopted, despite the fact that in the past, it was boys should surpass the girls. But now I've come to understand that boys and girls should have equal treatment. Then we are fighting illiteracy, whereby illiteracy is the cause of everything, to see that they can be, everyone should be literate and able to stand by himself or herself. And the last is to see that we have a special program to fight the mind setting, which is very critical in this generation of this called digital era. Because people have adopted very many things which are not by our culture and which we are trying to fight. I beg to submit.
Thank you very much. Do we have young people from Busoga region in this room? How do you do it when you are celebrating milestones? So, Wechtiba, thank you very much. Okay, thank you very much, Wechtiba, for those submissions and the great initiatives in the Busoga region. We hope that the young people will engage you more to ensure that those are actualized and also they benefit from those programs that the kingdom has for the young people. So we'll come back to the Ministry of Education. Mr. Saidi Samba. Before one of the honorable members of parliament raised a political question. I don't know how you tackle it in its politicalness, but he raised a political question around the issue of pads for our young girls and adolescents. I think you'll begin from that, but also want to understand from this gathering, how do we strengthen partner collaborations to address the unmet needs of adolescent health services and information in schools? Thank you.
Thank you very much, moderator and everybody, for the opportunity to engage the Minister of Education and Sports and other government agencies in the discussion around the adolescent health. As the Ministry of Education, before I respond to the question is raised to me, we are putting a lot of emphasis on what we are calling the hand of rights. Like we have 5 fingers on a hand. And these rights have not been challenged. Anywhere, we have not been challenged. Right number 1, which is the finger number 1, is as long as we are talking about children, they have a right to education. That is very fundamental to us. A right to protection, as long as they are at school and between school and home. A right to participation, and I'm happy that here we have a good number of them. A right to health and well-being, which basically fits into what we are doing, and the right to play. Those 5 are very fundamental and very key to us on a day-to-day basis. The issue of pads, it's good you well put it. It's a political one, and therefore requires a political answer. As the technical officer from the ministry, the discussions they had at that level maybe didn't trickle down to us so much. So I think it could be answered appropriately by the political leadership of the ministry. I will not take it beyond that. How are we strengthening partnership? In responding and ensuring that we address the 5 core rights. As a sector, we are closely working with each and everyone to ensure that we deliver the services to the people. And under all those 5, we have worked with a number of partners on a day-to-day basis. We have worked with peer-to-peer, we are happy to report. We have worked with Save the Children on a number of health interventionists. We have worked with the SEHAD on a number of interventionists, Sexual Reproductive Health Alliance. We are working with the religious leaders, our partners Save the Children. Leave alone the big ones, the UN family. We are closely working with all of them. How are we doing it? The ministry works through a number of structures. We do have what are called technical working group. One of them being the health technical working group, where we draw membership from the different departments of the Ministry of Education, Ministry of Health, my colleague Olivia is here, Ministry of Gender, Ministry of Internal Affairs, the civil society, the religious leaders, because more than half the schools are faith-based founded. So we are doing that, and we are proud of that. I'm happy to report that we also, in an attempt to strengthen partnership and collaboration, we are happy with the partners because we have moved on a very long journey of developing the national school health policy. Wherever we go, they ask us about that because we are talking about adolescents. And I'm happy to report that now this is before cabinet. It has been a long journey, and we would like to thank each and every one for the contributions. We moved forward and backward, but I'm happy that now we are at the level of the cabinet, and soon I do hope that before this year ends, we will be able to have the national school health policy, which will be the overarching document for all of the health interventions on nutrition, reproductive health, mental health, sexual support, and physical education, and all the other components. That one will also be, we are happy to do so. We are closely working with the partners also, as I said, to do direct implementation in our education institutions. I'm happy peer-to-peer, I supported us in a number of districts, Luero and Kamuli. Plan is in Kamuli and Tololo. They have exited Luero, I think. Save the Children, you have done a commendable work in Wakiso, the Renzol sub-region. We have done quite some good work with them. Reproductive Alliance, we have done a lot of work in the Teso sub-region and Busoga. And therefore, all the issues that have been raised about adolescents as education sector and as a government entity and agency, we are doing something basically through the partners. This elephant is too big. Government cannot do it alone, but also just to emphasize that CSOs and the NGOs, they support the government on delivering on its mandate. So when you see a CSO, you don't say where is the government, because CSOs and the civil society, NGOs and so on, they are representing government in ensuring that the service is delivered within that particular area. Thank you very much. I submit, moderator.
Thank you very much, Mr. Said from the Ministry of Education. We'll hear from Dori Ajok. We appreciate the initiatives and the investments by AMREF in different regions addressing various adolescent health issues, but we are still aware that we have a gap in financing for adolescent health issues. We need our government to invest more in adolescent health issues. How, from your perspective, do you think we can improve on our domestic financing to address adolescent health issues?
Thank you very much. I'm honored to be on this panel. I would have wished that an adolescent was here with us as well. But all the same, I hope in the fourth dialogue, we will have adolescents here telling us as the key stakeholders of this convening. However, back to what you've asked. By now, a lot of presentations have been made on health financing. I know many of the adolescents maybe did not pick it, but I will try to simplify what I speak to as much as possible. Where you feel you do not understand it, especially to the young people, I will still be around. There are a number of officers here from Save the Children Plan. Please walk to any of us and ask if you want to understand further what these things mean, especially around health financing. To start with, what is health financing? In the simplest way, it is the money we put aside for health. This is the simplest way I can say it to you. And how, which other ways do we put money out for health? Sometimes you walk to the facility and buy a Panadol, you're financing health. Your mother will pull money to buy a malaria tablets, you're financing health. Government will send medicine to the health facilities, they are financing health. NGOs will come and put money into the pool so that NMS can have drugs to bring to the health centers. We are financing health. Who are the biggest health financiers in our country? The government of Uganda, by far, is the biggest, and it is from us, rightfully so. We contribute the revenue, and the revenue is put back into healthcare. But also we have the donors. I know a couple of organizations here put money into the pool that gives medication and pays services, health services to be delivered to the young people and the community. But also I cannot ignore, Mr. Okwi is not around. I know very many young people wanted to ask him a lot of questions about his presentation. If he's outside there, I hope he can come back so that the young people can engage him. You, the community, contribute a lot to health financing as well. Like what our member of parliament said, when you cannot find the service, you will have to sell that goat and go and look for the service. If you cannot find the service at the regional referral, they're going to tell you there is this specialist in Kampala who is very good. You're not going to see that specialist on government money. You're going to pool your personal money. Sell land. I know people that have sold land to fly for medication. Not because they have the money, but because it was that much needed. It was a matter of life and death. I do not want to take a lot of time. Our time is far spent. What is government doing? We talked about the department. We have a whole department, by the way, or especially under education, which I think that department sits in MOH, Department on Adolescent School Health. That I wanted to also inquire from David, how much money does that department get to implement adolescent health in schools? This is where most of the adolescents are. Age 10 to 19, we know most of our young people, by the time you go to senior one, probably you're even 20. But between upper primary and lower secondary, that is where our adolescents are. How much money is government putting in that department to implement? I would have loved if David was here, surely. But also, someone talked about the sharpened plan. I will not go the Ramka sharpened plan too. I do not want to go into detail of that. But the priorities of the sharpened plan are, and I will read them to you as they are. One is to end preventable deaths, especially among youth and adolescents. That is one, but also to promote health development for adolescents and young people. I wait to see how this plan is going to be implemented, but I hope it will be well funded. There's nothing that can happen without funding. So bringing me to my point, what can government do? There are a lot of things that as private sector we have tested, and it is working. I'll give an example of the HEROES program, AMREF and its partners with funding from the Netherlands Embassy. We are implementing the voucher system, for those who have heard of it, where a young person can get a card, small card like the lunch coupons that we have. That card allows you to get services at the health facility, services ranging from family planning, response to SGBV, treatment, you name it. In fact, we wanted that card to go as far as if you're admitted, we even provide you a meal and transport while in hospital. And all that is aiming to what? Financing healthcare, because the burden on people in the community, poverty is real. Somebody mentioned it here. We keep talking about poverty, but it is a reality. I've worked in Busoga for 4 years now. And believe me, I have seen households where there are 4 wives in a small room, all convening with their husband, communing with their husband in a one-roomed muzigo. If that is not poverty, I do not know what it is. The fact that you can accept to be there and procreate as a mandate. Because when you're married, God said, you must give offspring. That's the only way we assess that. So the voucher system is working, but is it sustainable? That is a discussion for another fora. We know most of these health financing methods are, sustainability is a discussion we need to seriously have. But right now, it is tested, it is working. And how do we channel the money back? Through results-based financing. A part of the project is supporting government to roll down results-based financing at the health centers. Now for the young people, results-based financing in the simplest word is, you do work, you do it exceptionally well. We shall give you money to help you do the work that you don't have money for. That is what results-based financing is. And government has been doing it in partnership with a number of CSOs. But if results-based financing could be made more intentional to respond to adolescent health issues, there's a lot we could achieve. There are a number of indicators, but adolescent health is not the top ranking. There are so many issues that these health facilities they want incinerator, they want a delivery bed, they want more staff, they want a fence, they want a borehole. So there are so many needs that at the end of the day, the most pressing need is what results-based financing will put the most money in. But we need to understand that adolescent health equally is very pressing. For the parents that are here, many of us when we join NGOs, and these are just ideas that I'm giving, we are given an option to have maybe about 3 or 4 dependents on your card. Then when the insurance companies come and say, but you can have even more, you say, when they fall sick, I'll go to hospital. Purchase these premiums, especially these people seated in the front row. Who can afford to purchase these premiums for healthcare? If you can, why not? Put all your 6 adolescents on the healthcare system. Go to UAP, or I don't know, there are quite a number, ICEA, there are quite a number out there. Buy the lowest premium, at least to save you from a malaria or a typhoid. But parents don't want to hear that. They say, government etuyambe. Government has no money to help everybody. Those who can help, especially the CSOs, we have these opportunities. You can explore. But I've seen even telecoms bringing up these innovations of health insurance. MTN has something around, my people, do you access these services? There is healthcare on MTN. You pay some money. When you get a problem, they give you a loan, which you pay slowly. Have you heard of that? Have the young people heard of it? You save some money. When you get malaria, they will give you money, which you will pay back slowly. Those are some of the things we can explore. But also government should support agencies like that to broaden these approaches or these innovations to cover all young people. Community health insurance schemes. I know young people, I'm coming to you. I work with a team of young girls in Namutumba and Bujiri districts. They have formed youth-led VSLAs. And their teenage mothers, all of them are below the age of 19. But in their saving, and they put it clearly in their constitution that we save for health, for my health and for my child's health. And if I have an emergency in health, I can take that loan from the VSLA group, interest-free, and pay back just that amount that I took. But believe me, it has saved very many young people from children vomiting there until you get well. In my culture, they say you heal like a cow. When cows fall sick, we say you will be fine. If you die, we eat the meat. If you survive, we thank God. So if there are those home organic VSLA groups or saving groups that in the communities young people can form, where you set your constitution yourself, make it as low as possible. These groups should not be to make money. Usually when I hear them saying, we put an interest rate of 5%, 10%, I said, but surely, are you here to make money or to help each other? So those saving groups most times help. This is where these young adolescents run to. But you know that can also not work alone, and I'll come to that. We have been speaking about the National Health Insurance Scheme for a very long time. I know many people on this panel and in the audience have heard about this. What does the National Insurance Scheme look at? In summary, and in the simplest way possible, healthcare that is available for all of us, but we contribute some money to make sure that this healthcare reaches all of us, even the most underserved. At a national level, all of us contribute one way or another. If that scheme is actualized, then we can now start having discussions. We wouldn't be having discussions of health financing now. We would be looking at cross-subsidizing. The ones that have a lot How can we use their money to give the ones that don't have? But I know this cannot work or even be successful in isolation. There's a lot that we will have to do together with government, partners, stakeholders, together with government. It will need a very multi-sectoral approach. Someone talked about a multi-dimensional, because health financing cannot excel in isolation. The young people don't have money. How many young people here have an income? Many of us are waiting for this per diem of being here for 2 days, and then we'll be loaded for the next 3 months. We are causing inflation in our villages. But do we have where we get money, constant income flow? We do not have. Ministry of Health needs to work with Ministry of Gender. Ministry of Gender has the PDM. PDM should be helping these young people, and I hope young people are tapping into these government programs. PDM should help to build your economic capacity so that you're able to invest for health and also save for health. But also, the school health program, we need funding for it. I needed to tell this to Mr. David. Fund it. Let's not just create a department and leave it there. But more critical is, if we are to excel in implementing health financing, then some policies are going to have to be amended. Otherwise, either we are going to conflict with the insurance policies and the whole insurance framework, but also we need to have where do they operate. I have my health savings association in the village. Under which policy which policy protects me under this scheme, before somebody runs away with people's money? But also technical support will be needed. These people will need to be trained to understand how to run those insurance schemes at the lowest level possible, down in the communities. I could go on forever, but our time is way, way, way spent. Thank you.
Thank you very much, Ms. Ajok. Very tough dynamics around financing for health, both the easy ones, the difficult ones, but also we come back to the realities when we get back to our communities on what is possible, what is practical, and what is tough. Thank you for those insights. As we get to the last panelist, our young person, Namtebi Maureen, we want to hear from you on behalf of the young people out there. You've been discussing with your young people, you've been engaged in several spaces, but you want to understand from this space with very many stakeholders, how do you think the young people can be better? We know you are being engaged, but how do you think young people can be better engaged in program design, implementation, but also accountability of those programs around adolescent health? Please.
Thank you, moderator. By the names, I'm Namte Maureen, a peer educator supported by Plan International. I'll come back to the question, how are we supported, we as the adolescents? First of all, as Plan International engages the peer-to-peer educators. These peer-to-peer educators, it is a structure and it is selected by the VHTs, the health workers, and the CDO that helps Plan to identify those youths in the village or adolescents in the village such who are able to speak up, to read and write. These peer educators are trained to be well versed with the information such that they can pass to other fellow adolescents. When they go back in the villages, in the communities, they form 30 group of participants and they give out that information that they gained from the training such that the information passes on wider. After a period of cohort, these 30 participants graduate. And after graduating, they become VHTs sometimes. Then others are selected. This is done in order to make the information go wider. And it helps us as the youths. Second to that, there is a structure of VHTs. These VHTs, I hope everyone here knows what we call a VHT. VHT, these are people these are trained people in the village that helps the youth to engage others. Then they give out services like family planning. They give services like first aid. I hope everyone knows here what we call a VHT. Third to that, we have the model parents. Plan has helped us as youths to train those role model parents in the communities that can talk to other parents as well as engage the youths in order to make us sustainable and be on our own. Fourth to that, we have a structure of men action groups. These men action groups are done in order to engage the men in the community, and these male action groups, they mainly do their sessions to those places where men meet, like the border stage, the drinking points, and so on. My next point is there is these community influencers like the cultural leaders, religious leaders. These are mainly selected in order to pass on the information on negative gender norms and social norms in the communities. I beg to submit.
Thank you very much. Those were great insights from the engagements of the young people at various levels. We want to give an opportunity to the audience. We'll have an opportunity to listen to only 5 people for purposes of time, and we have our panelists wrap up. So if you have any comment, any clarity, any information, kindly raise it very precisely and briefly. Pass on the microphone. Can you hold one microphone? Start with her. Please be very brief and straight to the point, because we are out of time. Thank you.
Thank you so much. My name is Jacob. I come from Nwaya district. I've been listening to all the presentations that were given. I want to say the only place we can vividly see a miracle done is in our mother's wombs, because that is the only place where the input is less than the output. The government of Uganda puts very little money, and they expect us to see a lot of output when it comes to this. And when I heard the big man was presenting on how budgeting is done, honestly, I felt we are being, I don't know, let me use a simple word, we are being lied to. It is our mandate. I come from the local government, I'm a councillor 5. It is our mandate, just as the Honorable Member of Parliament was saying it. We put money there, but somehow, somewhere, how this money gets along the way, we do not understand it very well. So it's therefore our own mandate still here as all of us to see that money is put that is going to be adequate. Most of the money that is being put in the budget, if you look at it carefully, goes to inland travel, outside work, training here and there. Nothing touches the adolescents as we are here for. Secondly, someone's vividly said it on TV, that for them, if they're sick, the president flies them out of the country. I don't know whether you watched that news that day. Will our adolescents also be flown out of the country? That is a very clear sign that this country is sick somewhere, somehow. Because if someone at that capacity can tell us that if I'm sick, I'll be flown out of the country. Now, what about me who cannot fly even to Modago? Will I really be safe in my own country? So this still goes back to leadership. This still goes back to us who are serving. Finally, if you go to these hospitals, you'll find even when a nurse is sick in their various hospitals, they cannot get treatment from there. They cannot even go and get treatment from another hospital in another district. They end up going somewhere else. So that shows us very well that Ministry of Health, if you're here, please, can you open your eyes and ears and mouth and everything and make sure we work on our health system in this country, for God and man country. I beg to submit.
Very powerful. Those were general comments. If you have any targeted question to the speakers here, you can target it. If it's a general comment, you can also mention it's a comment.
My name is Wakobera Shamim. For me, I'm going to, first of all, target the Education Minister. Today, in today's Daily Monitor, Madam Esther Chozira for Nudipu, CEO Nudipu, has aired out that only 2% of the children in primary school are children with special needs. This is the reason for this percentage is because of the poor accessibility standards in the schools. What are you doing to help children with disabilities stay in school? Another thing about health, we are looking at provision of medication in the hospitals. Sunscreens, you have really made them tax-free, but why aren't they availed in the health facilities? Because last time, during the celebration of Albinism Day, the representative for persons with albinism was requesting the government to avail sunscreens in the health facilities. Because look at a person from Karamoja coming to Jinja to pick just a sunscreen. So we are requesting that sunscreens are put in the health facilities. Then also, the information that is provided in the health centers is not transcribed into Braille. We don't have sign language interpreters in the hospitals. What are you doing? Thank you.
Thank you very much. She's raising very strong issues on equity in access to services. I'm sure the panel will handle that. We have 3 more to go.
Thank
Please
you so much.
pass on the mic.
Thank you so much. My name is Masiga Dennis from Namaingo district. My question goes to the religious leaders. You find out that most of religious leaders, they don't accept young people to talk about sexual reproductive issues at the church. And I always tell people that there is no medicine which can cure someone who is sexually active, apart from just talking to that person. How are you going to help us to talk with those people? Because majority of religious leaders, they don't allow, they think that you are spoiling this child. Yet these are people who knows everything more than us. Thank you so much.
Thank you. Awechtiwa will respond to that.
Good afternoon once again. I'm by the name of Mutesi Miriam. Before, I want to just air out something we had before we went for lunch. Someone talked about menstrual napkins free of charge from government. And they aired out that there is a budget that was passed and there are pads that were purchased. Someone missed and took us for lunch and the discussion had ended there. So I'm still airing that back to the representative from Ministry of Education. We want to know what went wrong. Where are the pads? Then,
Where are the pads?
Secondly,
The question, be
yes,
precise.
where are the pads? What went wrong? We have condoms free of charge everywhere and scattered in every place, but we do not have menstrual pads. At least we should also put that in place. If they are purchased, let them be distributed in health centers, in public places, and also in schools so that our girls stop dropping out of school. My other question is on behalf of the adolescents out of school. We have so many young people that are out of school, and these are young people who have been exposed. So we want to, there are so many questions on access to contraceptives. And this is something that people are pulling out. All they say, you are applying for girls to go for sex in the name of accessing family planning services or SRHR services. So we want to also know, where do you live the young people that are not going to school, they are not being employed, they are not being put anywhere? What solutions do you have for them on table? Thank you.
Thank you. The speakers are outsmarting me. Each one has like 5 questions in one. I request you make one question, one comment. We give a chance to the
I
rest.
assure I am going to make one question out of 3. Good evening. So my name is Joash from Richerhand, Uganda, and I was clearly listening to the panelists. One of the panelists from Busoga say that they have school programs that do engage young people, and the question goes to the Ministry of Education. We have our own schools. When I say our own, I mean government schools. But when we seek to go there and conduct healthy talks, these government schools don't allow. And my question is, are there strategies we can follow to see that at least these schools allow? It's very simple, because yesterday, they presented the increase of STIs and UTIs in Uganda. And it's a matter of talking to them, behavior change. You change their behavior, the way they behave, and we can change. Thank you so much. If it's possible for the minister to share with us as well how they are doing it, so that we also copy from it. This is happening in Kampala, Wakiso, and Mukono. Thank you so much.
Thank you. The mic is one side. I request
Thank you so
that
much.
after
Once
that we
more,
pass it
I'm
to this
called
side. Thank you.
Adia Mary Immaculate from Karamoja. We have been talking about safe spaces, and we all know the benefit of a safe space, especially in a school setting. But looking around, in most of the schools, we don't have these safe spaces. My humble appeal to the representative of the Ministry of Education is that, can we make it a policy to have a mandatory safe space in each school? Thank you.
Thank you for that. I request we pass the microphone to this side as well.
Thank you. It is actually unserious or to pass me without a microphone, and yet I was the first to put up the hand. Thank you. My name is Okumu Kadokech David. First, I want to actually bring to attention to the person from the Ministry of Education that Plan International in Tororo, it is evaluation stage. I think all the projects are now out. There's no more plan in Tororo. Thank you. 2, in the issue of national health and insurance scheme, I want to know the proportion that is gazetted to the adolescent team in Uganda. I think I need to read that paper, because most of these projects people talk about in the government arena, none of them has been, actually no evaluation report has been yielded, more so in instance of youth empowerment. So I think I need to see how what it contributes to the adolescent sector in Uganda. Then lastly is the insurance scheme. Please, I think I captured it as the health venture system. As a statistician, the total population of Uganda, only those who subscribe to health insurance is less than 2%. So how sure are we that this is going to be taken into account? Finally, to the Minister of Busoga. Ideally, I am a PW advocate. I am the founder of Educate Every Child Africa. I've traversed, I think, 26 countries in African continent. But on your presentation, you were focusing a lot in the issue pertaining health and that living the highly marginalized community. These are the PWDs. My sister, I think, was speaking about it and I clapped alone. Ideally, we need these people to be highly embedded in most of these programs, more so in cultural institutions too. Thank you.
Thank you very much. I'll have only the two last hands and we close this. The lady in green and the lady at the back, and we close
Thank you
this
so
session.
much. My name is Daged Mustafa from Plan International Kamali. My issue is about the greediness in our kingdoms, at our districts, in our government. When it comes to these people coming from the donor-sponsored organizations, for them, these are people who are almost coming from different regions from where they are working, where they're operating. But when they try also to get into the government offers, they are limited by the district officials, by the government officials. For example, I'll use the district bursaries. Someone is working for Plan in Kamali, but you never know he's even born in the West. But he's coming to work in Kamali. There comes a chance. He gets to know the bursaries are district. He tries also to go, see whether he will get a chance. When he reaches there, he's meandered all around, wait. And what is happening behind the stage is the chairperson has taken a slot. The remaining slot is for the MP of the district. The other slot is for LC3. These people working in the alien regions are not being brought on board to also get these chances, such that we strengthen our working, how should I call it? Our working partnership. Please give this a chance also to get governmental offers such that they will work for us in our regions, because otherwise they will just sit, wait for the contract of the organization to end, and they go back to their places without us benefiting.
Thank you. Point taken. Politics of bursaries.
Thanks for giving me this opportunity. My name is Malema Rose from Mbale. My question is to the government. The government has come up with some programs that they have implemented in the communities out there, like we have the Emioga and the PDM. So how is it helping these young people who are outside there and of which they do not have the national IDs, and of which the most programs which are implemented there, they can be accessed by only those ones who have the national IDs. So how are they helping us?
Point noted.
Thank you. I'm Nationalist Liner from Uganda Cares AHF. Thank you, Reverend Nathan. My concern is about how best can religious leaders help us in breaking some of the religious myths concerning adolescents. Like, among of the adolescents living with HIV have a belief of the religious leaders that heal HIV. Muina mateeka ki eri abo nanagiramu naye eri abo abagamba abatugamba mbu bawonya HIV nabo abo abafaaza kale munansobola kyogera wento abagamba tukozesa condom abanaddiini kyembuuza mulina mateeka ki cause bebamu kale kyekyo.
Point taken. Imi, I request you bring back
Sorry
mic.
for taking the mic.
You need to move ahead.
My question goes to the minister, the representative of education. My question goes to the whole government as a whole, because as of all us, we know that that a child especially adolescents, are better safe when they are in school. So when we speak about the hiking prices of education in the private universities, the government takes us back to the public universities and the public schools. Yet the prices are still high. I'm speaking from experience that I've been a student studying from public schools ever since primary. But ever since then, prices are increasing and they are not decreasing. Yet a Ugandan child has a right to education, but they cannot even afford it. Adding to that, we have poor sanitation in government schools, starting from the primary and the secondary. Yet we are the ones talking about adolescent health. What can we do about that? That question goes to the representative.
Thank you. The last person, please. You bear with us because of time. Any more issues, you can always interact with our speakers. Please go ahead.
Thank you very much. The government pledged under SGD 3, one of the priority areas is health financing. And of course, it intends to improve financial risk protection and reduce out-of-pocket health expenditures. Now, what strategies what system is the government intending to adopt? Because we have a lot of money going unaccounted for, and you find that probably part of this money would have been for the adolescents. Secondly, ownership. You find that when a partner comes to implement in a certain, say, district, it comes with its budgets, with clear targets. You find that instead of the district persons, say civil servants, I speak this in good faith, you find that the activities that the organization is implementing to meet a certain outcome, you find that these persons, the district personnel, come, okay, they channel the money that was meant to do other activities and leverage on the activities that are implemented by partners. Where does that money go? Who is following up those people? And who is...
In summary, please.
Okay, thank you very much. And the other thing is ownership. Till when will the government keep on looking at these people that are not taking ownership of some of these interventions? When an organization, an NGO comes to a place, you find that we walk through the district, but of course, you'll be left to do almost each and everything. You follow up the people, you go to their offices, they are not there. Who is following up on these people? Until when will they keep running around, probably looking for... Thank you.
Thank you very much for that submission. In the House, I want to recognize the presence of Commissioner Ronnie Wahatunjire. You're most welcome to this gathering, and we'll receive you later to officially close this gathering. You've come at the right time when people are making submissions on how we move forward. So I want to hand back to our panelists. You are making a response where necessary and making a final parting shot. 1 minute for all of us, parting shot and a response to the comments. Yes, please.
Thank you. I think I have two issues to respond on. One is our behavior change in Busoga. This one I tried to explain that in Busoga we have a chigangu. That is an organized way whereby we pull all across the region adolescent children for a retreat. And that retreat has very many things that can be given, which includes the mind setting, how a good Musoga could behave. They get even entrepreneurship trainings, and the like. So that one is catered from there. Then the second one is on the PWs. This one, Soka Kingdom has a very big stake to ensure that PWs are inclusive in its programs. And I would like to inform this house that over 100 PWs have benefited by getting the wheelchairs, getting the, I don't know how they call those sticks for the blind, which they use to move, and also the clutches. So they are well inclusive in our programs. Thank you.
Thank you very much, Oichtiva. We do the next.
Okay, so for me, I didn't get any question. So meaning that civil society organizations are doing well to engage people, adolescents living with HIV. But my take on this, even as we are talking about SRS, products are not available, contraceptives are not available, I think the reflection we get from the population expert, where he asked us that where are the 40% of young people aged 19 to 30, where are they? I think that's a very critical question that we need to reflect on and try to see what's the implication of that. Because this is a population that will be a burden to our country over years to come. And so I think the lenses we are looking at adolescent health is the lens of consumption. When you ask ourselves to contribute resources, we think that just consumption, but I think it's an investment issue. Because once we invest right in our young people, it means that years to come we shall have productive population that will not be a burden to us. I think as a country we need to reflect on what's the cost-benefit analysis of investing in adolescent health and not. I submit. Thank you.
Thank you very much, Mr. Magara.
Thank you very much, everybody. I think I received the biggest number of questions on behalf of government of Uganda. And I thank you for your active listening. I'll try to respond to some of them, but also I think at an opportune moment, Commissioner and Minister of Health will be coming in, so we will be also responding to some of these issues. I will summarize them. There are many, but I will take less than 3 minutes. Poor hygiene in schools. Hygiene is a responsibility of everybody. It goes back to mindset. Facilities are put there. When they are put there, they are not unhygienic. But who makes them unhygiene? And what is our responsibility of ensuring that we are in a clean environment? So it comes back to especially you, because it's part of your responsibility. Government program and ID, my dear, the country is moving. For you to justify that you need the services, you're Ugandan, first get an ID. Any adolescent actively engaged in advocacy, even if you are not an adolescent, at least some of the basic things you should have is an ID. So if you don't have a national ID, then you'll be branded to be irresponsible by now, because even children of 13 are being registered by NIRA. So why should you lack an ID? You should make deliberate efforts to ensure you get the ID, use the ID to demand for services, service-driven. Safe spaces, making it mandatory. Yeah, the government is aware about this, and under the revised guidelines for basic requirements and minimum standards, this is well captured. Issue of access by the adolescents to schools. I was part of those that designed with Ministry of Health the YAPS model, and it was designed that the young people will have access to schools, but it should be done in a structured way. Health facility where you are attached, in liaison with the head of the institution, then you program and say, on this day at this time, come and give these health talks to the adolescents. It's a good one. Adolescents out of school and access to contraceptives and the solution. I think Commissioner will talk about that. How should they be supported? The part is what went wrong. When I was starting, I said that was political, and therefore it requires a political response, and me, I'm a technical officer. So I can't explain really what happened. Sign language in hospitals, I think Minister of Health is aware about this, to consider sign interpreters, but also where they don't even have, they have put some signs to ensure that they, at least they are given direction where to access. Commissioner will talk more about this. The sunscreens and at health facilities, I think that could be talked about. Access to facilities by persons with disability. When we revised the building plans for Ministry of Education, it makes it mandatory to have ramps everywhere. And it's one of the standards that we look at even next week as the team will be going to the field. This is one of the things. So we do consider that persons with physical impairment should be supported to access the different facilities at school. I thank you so much. We should do a lot of advocacy. We appreciate everybody for all of these efforts. And as President Sisi Ramaphosa put it, there is nothing too small when it comes to changing this world and the environment. Thank you very much.
Thank you very much, Said, for those submissions.
Yes, thank you, dear team, for the questions. Yes, religious leaders, some of them are not on board, especially on issues to do with adolescent health. Like I told you before, majority of the religious leaders in the country are not going to give us what they don't have. So this calls for more engagement, more religious dialogues with the leaders, capacity building, and sensitization, especially about health. And this is a call to the partners in the room. You have Reverend Nathan. Use him to reach to the religious leaders. Because in the religious structures, for you, you are wananchi. You get that? For instance, in the church, me, I am a clergy, for you, a laity. We are at different levels. For us, we are a class above. You get that? So you cannot claim to engage religious leaders if you are a class below. Please engage us because we have enough experience, especially in theology, science, sociology, psychology, and other contemporary issues. So engage us to dialogue with the religious leaders and create the change that we need. Some of you where you come from, your leaders cannot talk about sexuality issues. Yes, just with the Ministry of Education and Health, recently we just had a validation meeting for the life skills and health education framework, initially which was being called the sexuality education framework. It's now called the life skills and health education framework. And as a board member for the O3 program under UNESCO, I was there and gave my input, especially for the religious leaders. So it's coming out very soon, and I will request that we continue engaging. Now, one of our young people said that their religious leaders are saying don't use condoms. Now, when we come to such spaces, we have an issue of rights versus obligations. As me, I have a right to having sex. In fact, if I come out and I declare that I cannot have sex, I can even be penalized. Because I have a right to sex because I can handle the consequences of sex. You get that? When I have sex at home, yes, I have now 4 children. All of them are in good schools. They have the best education. They have the best, care and whatever. So I am here to tell you, your religious leaders tell you, please abstain. Yes, you should abstain. Who has the right to having sex? The only person who has the right to having sex is a person that can handle the consequences of. the only person that is allowed to have sex is a person that can handle the consequences of their action. Don't tell us that you guys have a right to sex and you cannot buy condoms of 1K or 2K. Don't tell me you have right to sex, yet you cannot take care of a pregnancy. Young girls, don't tell me you have a right to sex, yet you're having sex with a fool who will just run away when things turn the other round. You get me? So the only person that has a right to sex, to having sex, is a person that can handle the consequences of what? Sex. Condom use, they may tell you, don't use condoms, don't engage in sex. Okay, now you have the condoms. You are having sex in the bush, in the gardens, in unfinished houses. Yes, you have got the condoms, but you're using them while drunk, while excited, in the disco, in everywhere. Yes, you have got the condoms, but you are having sex. Why are you having sex? For enjoyment. What is enjoyment? You cannot answer. I am having sex for revenge. Yalide kabalagala wange, yalide chapati, yalide panu wange. That's why you're having sex. So, as young advocates, as your parent, we don't want young people to have sex just for enjoyment and just for purposes of just sex. Can you handle the consequences? Yeah? Hitler you cannot handle, I'm sure you cannot handle. And I'm sure that not so many young people here can handle the consequences. So please, wait. Sex is not going to run away. You will find it. We also found it, and we are living with it. But also, even as the married, we are abstaining. Yes. Now I've not been home for 2 weeks. The other day was abroad. The other day was up country. 2 weeks. But I am abstaining. You get that? But it does not mean that I don't have money. It doesn't mean that I don't have a car. It does not mean that I am a wananchi. It does not mean that I'm just a pauper. No. Whatever it takes, I have. But we are abstaining. So please, make sure that you acquaint yourself with the skills of abstaining. Because if you don't abstain while you are young, even when you become like us, you will suffer the bad consequences of reckless sexual behavior. Have a good time.
Thank you very much, Rev, for that sex talk. It was a serious one. I hope the young people have had. We'll hear from you.
I'll be
Joe.
very quick. There were a number of questions, but I'll just run through. If you need more information, we can still talk. Solutions to adolescents out of school. There's a lot government is doing. In fact, I'm aware Ministry of Health and Ministry of Education have a curriculum called the Journeys Plus curriculum that is on SRHR, SGBV. If you don't know about that curriculum, I know it's in a second or third draft, but we are piloting it to test it for government. Access that curriculum. It's both for in and out of school. But all the approaches these young people have been speaking about since yesterday speak to how out of school adolescents can be reached with information, peer-to-peer, there are peer educators, peer shifters. I've had so many titles that we call them here. All of them are addressing out of school adolescents. SRHR in school, how can it be delivered? To add on what the technical officer from Ministry of Education said, young people, before you go into school with information that is not appropriate, why some of those schools chase you away is because you're going and you want to demonstrate condom use. I'm just giving an example. You're not going to do that in a primary school. They will actually arrest you because you're now against the law of Uganda. What kind of content are you going with in schools? Is it age appropriate? Is it right for those young people? That is why ministry took it upon them to develop these documents that we are supposed to implement in these schools. Reach out to your education departments in the district, ask them how are we talking to young people in school around sexual reproductive health. They will tell you what you can tell them and what you cannot tell them in school setting. My fellow young people, safe spaces, that is a discussion I'll leave to ministry. I know it has been on and on and on, both Ministry of Education and Ministry of Health. National Health Insurance Scheme. the commissioner will speak to it. However, this is a direction that government wants to take. My colleague behind there, it is not yet finalized, but when it is, I know our government is very good in creating awareness. They will let you know because you're going to contribute to it, one way or another. So you will know how you're going to contribute, how even the poor of the poor of the poor will receive equitable health services. So it is a dream that we have, but the commissioner will add to that. How sure are we that people will buy these health insurances, the subscriptions and schemes? And well, mindset change is key. The problem is we are all convinced that government has money, government must give that money, but how much do we gather? It is not that much, that money we are demanding. I don't work for government. You may say I'm defending them. Realistically, that money is not that much. But we want it to solve every problem that comes up. Even someone who got an accident will say government enyambe. What can we also contribute? Yes, people have to change their minds that healthcare, even in the developed countries, you bear me witness, it doesn't mean all of them get free healthcare. There are those that still buy healthcare if they can afford. But this scheme is one of the things that could support us. I think that a lot of money is going to out-of-pocket expenditures. What is government doing about it? My colleague on the right asked that question. Well, I am not government. I do not know how much their out-of-pocket expenditures are at the moment. Probably the commissioner will speak to that. But I know that government has put in place structures to monitor how government money is used. In Bujiri recently, I saw a number of people being taken to Luzira in the IGG van. That is one of the structures. I have seen the State House Anti-Corruption Committee on ground. When they arrive in the district people know. When they arrive, people fall sick. That shows you that accountability is needed. And when you don't give the right accountability, you will go to Luzira and we talk from there. So there is something. I know there's a lot to be done, but government is also doing something. We cannot rubbish that. Okay, thank you, and over to you. My last word for the young people is keep asking those difficult questions. If your questions are not making people uncomfortable, you're joining in the conversation, the usual conversation. When you ask a question and you see people shifting positions in their chair, you're asking the right question. That is how change will be achieved.
Thank you. We'll hear from our young person. I saw someone bribing my panelists.
Thank you.
I don't know that they have to respond to anything you are bribing them with, but we'll hear from the young person.
Thank you. Me, as I live, this message goes to my fellow adolescents that as we are yearning to be elect, to be changed, let us first change ourselves before we get the information to change us. I remain Namtebi Maureen, peer educator, supported by Plan International, Kamuji.
Thank you very much, Namtebi. Are there any responses in regards to the cheats we received?
Thank you. There is another one, which is,
briefly,
how can you blame parents on child negligence? Yet some of our parents come from hard-to-reach areas, and they were born from these areas, and at all, they know nothing about how to handle themselves, also don't know how some of their responsibilities, parental negligence about parenting children. I think this one goes directly to, because we have at sub-county level, we have the community development officer. At the district, we have the probation officer and the district community development officer. That is part of their work to ensure that these parents know their roles and responsibilities. Then I think it is also a call to the CSOs around to see that they can continue with the sensitization on the child rights. Thank you.
Thank you very much. Ladies and gentlemen, join me to thank our dear panelists for today. Very tremendous conversations and insights. We can't thank you enough. May you please have your seats. That round of applause was not enough for all they have shared for today. Thank you very much to you all. We are supposed to close officially by 5:30 this dialogue. And we cannot even exceed by a minute on that. So I want to request Stanley Opio, wherever you are, to come forward and share with us some key highlights and actions from the past 2 days of discussion around adolescent health. And from that, we'll be inviting our official guest who will be closing for us at this dialogue. Stanley, you're welcome.
Thank you so much, Master of Ceremony. Good evening once again. I know the energy is low, so you'll just give me some few minutes to take you through the highlights that came through from yesterday, but largely today. I know also the commission came in late, perhaps also you have some heads up on what we discussed. So there was consensus that there are big strides that have been made by government in implementing ADH services. There are also achievements around sustainable financing, mechanisms on ADH services for many health facilities, and also there are good interventions that exist in our policies but require adequate funding for them to be actualized. So we are talking about financing today, and what has come through is that much as we are seeing progress, we still need a lot of money to be put within the adolescent health sector. Key observations that came through, we are seeing that much of the funding is not reaching the local government districts. Ideally, we are seeing only 1% at 1% of the funds of the facilities, like for example, national level hospitals, for example, are having 1%. Are comprising of 1%, sorry, but ideally they're taking the lion's share of the money. While district level, where there are 99% of the facilities, they're having only 17%, for example, in the PHC fund. This is something that we need to address as a consortium, as partners, as government. There's a prevailing question of donor fatigue that is coming through, that funds are shrinking within the donor community. Therefore, we need a lot of support from government, being the key duty bearers. CSOs are supposed to leverage the development of position papers to show that we are speaking to technicalities, but also to show that we're able to influence policy. So we need to have some kind of evidence-based advocacy to show that we continue the conversation of financing on adolescent health. There was a thinking that the government would shift its financing levels to household. I think this speaks to the aspect of the health, what is that? The health insurance, as I think panelists were alluding to. So this also will help us to make sure that people have money within households to finance health-related issues. And then there was a deficit in human capital development sector, and this also affects the uptake and progress of health services. And again, this has been mentioned wide and over that young people, once they don't have money, they can't access these health services, but also the capacity of health workers to deliver youth-friendly services, for example, will be at stake. What are some of the recommendations that were highlighted? We need to increase PHC funding to functionalize the health facilities from the current 17%, and again, something that we need to agree as CSOs and government, to what level do we want this to increase? But I think we can still use the standards that we have within the government. We have to develop an investment case for adolescent health financing. I know adolescent health is within the Ramnka sharpened plan, but I think we need a deliberate effort from the government to ensure that we have this investment case developed to make sure that we're able to really define what areas should we put in money around adolescent health financing. We need to have a joint implementation of adolescent health strategies by government and also CSOs and districts. We need to ensure inclusion and hard-to-reach areas for interventions, advocacy, supporting bridging the finance gaps through supporting ventures that are innovative, that can be able to have tax exemptions, but also to ensure that we are working with the already existing commodities that can be channeled to the health facilities. And then diversity of resources to bridge the gap of external donor fatigue, through pooling resources. I think this was talked about the consumptive taxes. For example, if you're taking beer, I think government has already implemented this. So I'm sure the beer takers know that there will be a 10% levy on your bottle of beer coming 1st July. We have to work in coalitions among CSOs and local governments to amplify and harmonize priority programs at national level and district level. We have to continue engaging stakeholders like this to make sure that we are able to continue the discussion about adolescent health so that we don't seize the pressure. Public campaigns, I think these are now activities that are at subnational level. We need to monitor and evaluate and report on deficits at subnational levels. I think CSOs that are here, this is a very critical area for advocacy. What's the value for money? How much money has been sunk, and how much are we getting out of it? And then, of course, the innovative green health initiatives and providing data, effective, efficient data to drive policy briefs and also costing for adolescent health. Yes, the human sector, the human capital development, of course, has been duly mentioned that we need to increase the budget allocation around that area, but innovatively. And also there's need to generate, to make sure that our key policymakers and decision makers are actually being deliberate in budgeting and also allocating funds to particular sectors in the adolescent health sector. And the last one here is to provide spaces for adolescents to engage, make sure that they're able to influence both at parish level, sub-county, and district. I think this speaks to the budgeting processes where decisions are made. So, ladies and gentlemen, that's a few issues that we came up with in terms of recommendations, but also issues and observations. I thank you so much for listening, and I wish you well.
Let's give another round of applause to Stanley for summarizing for us key issues from the 2 days. Imi, can you join me, please? Yes, Imi has been the co-MC for today. Please give her a round of applause for the support in ensuring that this day runs smoothly. Like we said, we are not exceeding 5:30 as promised. So on behalf of the young people, we are going to invite our chief guest. And in protocol, when the chief guest speaks, for us, we don't speak again. So before you, I've been Muhomza Abdul Karim, Head of Partnerships, Afia and Haki, and proud colleague and friend to Moses Bwire. We want to thank all the partners who have invested in this event, the Ministry of Health. We proudly associate, and we thank you for always accepting to be part of our initiatives as civil society organizations. It is something we treasure and we continue looking forward to. The partners here, Save the Children, AMREF, Plan, SEHAD, Uganda Cares, the Alliance, Reach a Hand, TICO, and everyone who has made sure that these 2 days run smoothly and made sure that the conversations we've had here are very productive and very pertinent as they have been. We look forward to engaging again, and we hope that the issues that have been raised will have a communique from this dialogue and ensure that it's extended to all the stakeholders that have been part of this gathering. So.
Hello, everyone. Let me take this opportunity to thank every young person here, the adolescents, the key stakeholders, and the civil society organization, everyone that has taken part in to make sure that this dialogue takes place, the third National Stakeholders Dialogue on Adolescent Health, all the CSOs. You've really done a tremendous job, and we really thank you. On behalf of the young people, I believe that whatever actions have been discussed here are going to be put into consideration. Let me take this opportunity to call upon our chief guest, Commissioner Ronnie, to come and give us our closing remarks as we see to it that this dialogue is put to closure. Thank you.
Thank you so much, co-MC or MC? Co-MC. So, Momza as the chief MC. Wow, okay, thank you. The members of parliament present in the House, I see only one, but I've been told that we had 7, and we're very delighted that you're still around to represent all the members of parliament. Officials from other sister ministries, religious leaders represented by Reverend Nathan, implementing partners, our young people, the honorable people for whom we are here today, all distinguished guests, ladies and gentlemen. Before I proceed to read the statement that has been prepared for the would-be chief guest, allow me make a few remarks. My name is Dr. Ronnie Bahatungire, and I work as the Commissioner in charge of clinical services at the Ministry of Health, and I'm here representing the Director in charge of curative services, who is the head of directorate that oversees reproductive, maternal, and child health at the Ministry of Health. He's not been able to make it, and it's the reason I'm here to represent him. We are very sorry that he wasn't able to make it. Speaking as a practicing gynecologist to our young people, I would wish to reiterate the statements that Reverend Nathan communicated about. Many of us tend to imagine that we have rights, but those rights are only enjoyed until when it gets the other way around, and you are requested or you are required to be responsible for your actions. And I do not know how many of us are ready for those actions. As a country, we are currently grappling with a very high burden of what we are calling teenage pregnancies. And the teenage pregnancies are coming with a very high burden of other associated complications. Just recently, on the 29th of May, we were commemorating the International Day to End Obstetric Fistula. And the key driver of obstetric fistula is teenage pregnancies. Why? Because when you look at a young person's body, God created us in such a way that throughout our growth and development, we are supposed to acquire or we are supposed to attain certain milestones that permit us to perform functions of life. Now, childbearing is a process that is required of a body that has become of age, because it requires the whole entire dynamics of a pelvis opening out to let the baby to come through, and then it closes. Now, if you are at such a stage where your pelvis, the pelvis is, to all of us, can you see me? This is what we call the pelvis. Now, if you are not yet of age, and that pelvis has not yet attained capacity to expand appropriately and then contract back, that means that the baby that you're going to be carrying, by all means, is going to be not in appropriate dimensions commensurate with your pelvis. What we call a pelvis that is not proportionate with the size of the baby. So what that will cause is this baby will come down by the natural mechanism of labor, but because the canal or the pathway where it is supposed to pass is narrower than the size of the baby, that baby will get stuck. And because the circumstances under which we conceive are questionable, Reverend Nathan talked about foolish men or foolish, I don't want to use the word foolish men, but men that are irresponsible or men that are not able to take up the responsibility of impregnating a woman. So you find that you've not been able to attend antenatal. You have been, when you conceived, you were thrown out of your home, say if you were staying in an urbanite setting, and you were sent to the village, and because you have been deemed as a social outcast, you find that you are not able to access appropriate antenatal care. What that will translate into is inability to be able to get assessment by professionals to determine whether the baby that you're carrying is actually proportional or can make its way through your pelvis. So you'll eventually, by natural means, get into labor, and you are in a place where you cannot access quick services. So that process will proceed because it's a natural process, and because you are not able to stop it, the bones themselves that are not able to allow that baby to come down will hold the baby back. And because you are not enlightened, you're not aware of the processes that are ongoing, and your mother or your grandmother or whichever person, many of us end up going to what we call traditional birth attendants, they'll keep telling us, no, continue pushing, the baby is going to come. And because they're not able to perform that assessment, you end up getting what we call obstructed labor. Now, this baby will compress against all the organs that sit within your pelvis. And key of them are the two tubes that bring feces or stool from behind and then urine from the front. So because of that continued pressure against these two organs, and this pressure is being exerted against bony structures which are firm, there is going to be friction that eventually is going to crush the soft tissues of those two soft organs. So eventually, you find yourself developing holes between the communication of the reproductive system, what we call the vagina, and the urethra or the bladder to the front. And that means you will continuously leak urine uncontrollably from the bladder or from the urethra into the vagina, and nothing will stop it. So wherever you'll go, you'll actually be leaking this urine. If the pressure is more to the back, that means it will be the rectum that will be crushed, and a hole will develop between the rectum and the vagina, because these organs are in close proximity of each other. Are we together? So when you develop a hole between the rectum and the vagina, then feces start leaking from the rectum into your vagina. Remember, under normal circumstances, the rectum is supposed to have control mechanisms by which you should feel the urge to go to the bathroom, and then you voluntarily empty. But because now you have lost that voluntary control, stool will just continuously leak between the rectum into the vagina, and wherever you'll be walking as stool leaks. So in severe forms, you actually can have both organs developing holes, what we call a recto-vaginal fistula. You have a hole to the front, and then you have a hole to the back. So you are leaking both urine and stool. So at the end of the day, that even expounds more on the already suffering that this person is going through. And these are things that can actually be avoided if only we ensure that we avoid conceiving when we are not yet ready. I'd wish to extend my sincere appreciation to Reverend Nathan for giving us the hard talk. These are some of the things that we tend to be shy about. We need to start discussing sex. Someone, while Reverend Nathan asked the question whether we were ready to take responsibility for our actions, said yes, we are ready to take responsibility for our actions. But I don't know how many of us would be able to do that. But all that said, I believe as young people in these 2 days, we have learned a lot, especially dimensions or facts to help us sail through life with ease without necessarily exposing ourselves to the dangers of early childhood, pregnancy, and parenthood, as we have seen. For those that eventually end up delivering these babies, they suffer because they themselves are babies or their children, and they are required to care for these children. Some will actually end up losing these babies. So you have a triple tragedy. You have a baby that has been lost. You have holes that have developed in your organs, and many a time you have been cast out of society and you are left to yourself. And you find it very difficult to integrate or live amongst other people. So these are some of the things that we believe can be avoided if only we heed the guidance that has been given unto us as young people. And I would wish to appreciate the team that has ably delivered these messages for the past 2 days up until today and this time when we're here. On that note, allow me read verbatim the statements from the Director, Curative Services, for whom I'm here to represent. As already announced of the protocol, colleagues, allow me appreciate all the partners that have enabled the third national stakeholder dialogue on adolescent health, peer-to-peer, Save the Children, as all have been listed over here, Plan International, and all the others, including Reproductive Health, Uganda. We recognize as Ministry of Health all the stakeholders that have contributed to this event, and we are cognizant of the effort that our stakeholders have made in this today event, especially where the adolescents make up a significant proportion of this country's population, which is by far a very young population, and all the challenges that they come with. The health priorities have been underfunded, and this has been already highlighted by the two presenters earlier. And we believe that with good interventions and good policies, we will be in position to provide appropriate funding and resources to actualize the interventions to improve adolescent health in this country. As per the communique that was developed during the pre-event of this dialogue engagement and civil society organizations, these were the broad areas that were presented to us, including promoting holistic adolescent health and well-being, identifying and recommending innovative solutions for advancing adolescent health in Uganda, and then proposing possible ways of working and leveraging diverse expertise and resources to drive sustainable change in adolescent health indicators. And all this is done to ensure that we increase the proportion of the adolescent health, the adolescents that are accessing appropriate care and appropriate messaging at both national and subnational level. With the support of the legislators in the House, we believe we will be in position to appropriate sufficient resources to these interventions. Special gratitude goes to the ministries represented here: Minister of Education, Minister of Labor, Gender and Social Development, Minister of Finance, without excluding the Minister of Health. And we appreciate the process of budget allocations that has been done to date to ensure that we are in position to meet the needs of our adolescents and providing them with meaningful participation in matters of their health. I would also like to appreciate the civil society organizations that have advocated for budget allocations and financing of adolescent health interventions. And as mentioned earlier by the speakers from the Ministry of Health, there is a need to deep dive into the data to inform the decisions coming up with the policy briefs, as well as position papers that can be well utilized by all of us as decision makers to improve the performance of indicators under adolescent health in this country. And the Ministry of Health, working together with the Ministry of Education and the Ministry of Gender, Labor and Social Development, we pledge to continuously lobby the Parliament of Uganda to allocate more resources to interventions targeted toward improvement of adolescent health and ensuring that we develop social accountability and transparency through sharing and clearing of articulated program-based planning and budgeting, resource allocation, and the need to cost the proposals as has been tabled before the relevant authorities. In a special way, I would like to thank the adolescents, all of us in here as young people, for your resilience and active participation. And I take this opportunity to urge us all to move beyond the boardrooms and remain champions in the fight against poor health indicators, especially those that concern adolescents. Last but not least, allow me to say a special thank you to our partners, Peer-to-Peer Uganda and Save the Children, that have greatly contributed toward the convening of this third national stakeholders dialogue on adolescent health. I would expect at this point in time for us to clap for. As has been observed, this forum provides us as all stakeholders an opportunity to deliver effectively on accountability for the programs and interventions that we are delivering in the space of adolescent health, innovations, as well as demonstrating a sense of accountability for the resources that have been allocated to us and ensuring that these resources are effectively utilized for efficiency and sustainable programming. Colleagues, allow me demonstrate that with the demographic surge of young people that are entering into reproductive years, this presents us as a country with a great potential for development, and therefore I take this opportunity to mobilize all of us to remain committed to meeting the needs and aspirations of our young people, and together define the common future goal and purpose for these young people, for we are the role models unto whom they are looking for. Education, investments in health, including sexual and reproductive health, are all central to the young people's social welfare. And I believe this is one of the interventions and avenue by which we can continue mobilizing our young people in raising awareness of the young people about the concerns of their health and well-being. I say all this for God and my country. Thank you. And as the MC indicated, I should be able to respond to a few questions before I close the meeting. One of the concerns that was raised to me was the aspect of special concerns or special needs concerns for the blind and the deaf that come to seek for health care. I would wish to point us all to the revised human resource structures of the Ministry of Health, right from Health Center 3 up to national referral level. We have sign language interpreters that have been included in the structures. And the documents are public documents, and they can be accessed as evidence that this is happening. Colleagues, this has been as a result of we, as Minister of Health, being responsive to the needs of the community that we serve. The data that we continually pick from the facilities informs the decisions that we take over time. And it's the reason why the revision of the human resource structures was responsive to all the concerns that were observed and that were picked during the time when we were conducting the situation analysis during that time. Donor fatigue, how are we seeking to address this? As Minister of Health, there has been several interventions that have been undertaken, and these are hinging on integration of our activities. What you have seen here today is a demonstration of what exactly we are advocating for at Ministry of Health. When we go to speak to young people, we should not be going as Minister of Health alone. We should be going as all the relevant and concerned entities that have a role to play in addressing concerns of adolescents, such that at the end of the day, we utilize common resources and send a common message unto our young people, so that by the time we leave, there is a common ground that has been created amongst our young people. And therefore, we believe through integration, we will be able to deliver this common goal with minimal resources that are available to us. Our members of parliament will agree with us that the resources that are coming to the country have since dwindled, and therefore we need to be able to adjust our ways of life so that we can be able to live within our means. And the only way we can be able to do that is by moving in an integral manner rather than siloing, as has been the practice previously. The issue of sunscreens, especially to the albinos, this is one of the concerns, possibly. The burden hasn't come through very well, but it's one of the areas that we've picked, and we definitely will be able to respond to it. And all I can assure us of is the Ministry of Health has got what we call the essential medicines and health supplies list that is revised after 5 years. And during that time, when we are populating this essential medicines and health supplies list, we look at the common disease patterns we have in the country, as well as the health concerns that are required of us to respond to. And this is what informs the documents that we come up with. Just yesterday, we launched one that has been developed for the year 2024-2029. And we believe with our continued implementation of this, if that is one of the areas that comes up as of demand or as of need, then we will be able to create an addendum to this document so that they too can be addressed as a concern or as a commodity that should be provided unto the population. The Ministry of Health does not live for itself. The Ministry of Health lives to support and respond to the needs of the population. Our role is to ensure that we deliver a safe and efficacious health care unto the population. So everyone that has a concern is our concern. And on that note, I believe we will be able to respond to all the needs as shall have arisen. I say all this for God and my country, and on behalf of the Minister of Health, I would wish to declare this meeting closed. Thank you.
Thank you very much, Dr. Bahatunjire, for those very wonderful remarks. I wasn't intending to appear again, but we have been requested to end this dialogue in style with a group photo. We need a memory of all of us here. So I want to humbly request you, Doctor, before you sit properly, to join us on top of here, and we do that final group photo. So everyone, you are joining us in front here for a group photo, and then we head partways. Please join us in front for a group photo. All of us, we are taking the group photo. We are leaving no one behind. Yes, we'll fit. Colleagues, let's be a little fast. We do the group photo, please. Young people, we are not leaving anyone behind. So join us here for the photo. So some of you who don't know what happens up here, this place is very hot. So the more we stay here, the more it becomes hot for us, those who are up. So kindly, those who are seated, join us. We do the group photo and we part ways. If you miss this photo, you won't be in the 4th National Dialogue next year. So if you keep seated there, know you are missing a ticket to the 4th National Dialogue. Sauti team, guide us on whether you are capturing all of us.